We are live.
Okay. Hey guys, this is Ricky Sahu. I'm CEO of One Up Health. I don't actually see my video, Sebastian, so are we sure it's working? Okay, there we go. All right, cool. So, wow, what a year it's been. Actually, it's been 15 months since we had the last virtual health conference in 2020, when the effects of COVID were a lot more uncertain. And we were hoping to be in person just in a few months, but of course, that wasn't the case. And COVID has dramatically altered our day to day, from the most serious reasons, if you or your loved ones contracted it, to maybe a better work-life balance if you have the flexibility of working from home. And although COVID did take the cake on a number of headlines, what we wanted to do with VHC was spotlight this fundamental infrastructure that is being used to shape healthcare. And I believe everyone speaking and attending today is playing a huge role in setting this foundation for an improved healthcare experience throughout our country in a very different way. And this movement is really setting the bar for the rest of the world. There's nowhere else that has healthcare, clinical, and claims data coming together in the hands of consumers and applications like it is here in the United States. We should be really proud of that. And that's why we're super excited to have Alex and Steve from our federal government dive deeper into this topic at hand. And for those less familiar with the space, what I mean by the topic at hand is that on July 1st, just 1 week away, hundreds of health plans are required to meet requirements from CMS to enable Medicare and Medicaid members from their insurance companies get all their claims and clinical data via new standards called FHIR. And additionally, there are similar regulations for anti-data blocking for health systems that require the clinical data must be provided access to. And if you're here and in the know, I'm sure you've been working furiously over the last few weeks to months to make sure you and your organizations meet these deadlines. And I can say I know that firsthand with our team, who have had a bunch of late nights working with plans to make sure that we all meet these timelines just 1 week away. And ultimately, we believe that this will be extremely beneficial for the industry and for patients and members dealing with healthcare day in and day out. These CMS requirements are built on top of similar requirements from the ONC, where providers must make their clinical data available to any app of the patient's choice. And it's really the first time that both sides of the equation are coming together, and that's super exciting. In addition to our friends from CMS and ONC, we have a number of other speakers and panelists who will be building more towards this connected ecosystem and experience in healthcare. And they are representing the most prominent health plans in the United States, all the way to applications that are just getting their start, making data from these APIs more consumable by patients and their care teams. And these plans and apps will really be creating the future for the industry. But while we keep our eyes on the future and all the opportunity that lies ahead, I wanted to make sure that we step back and really reflect on what the industry is doing here. And it's not just healthcare technology, as an industry that's being impacted. It's really the broader, healthcare industry in general. Numerous conversations are happening about how interoperability requirements are creating opportunities for improved research, patient experience, quality, medical billing practices. But that's just the start. This standard is spreading like wildfire. Can't have a FHIR conference without at least one good pun to kick it off. And across HHS, there's a broad set of applicability. First, ONC and CMS really took a hold of this. And now CDC, NIH, FDA, AHRQ, they're all working with FHIR already. And from the industry side, it started with providers and applications. But what we're seeing with these new regulations is that health plans have a huge take in this industry now. And they are really diving deep with FHIR and really taking it to the next level with the combination of claims and clinical. Pharma, researchers, device companies, and many others are also starting to work with FHIR. So this is not a toy project anymore. FHIR has truly arrived, and it is a unifying thread across the healthcare industry. And all of this data coming together in a format that is shared will help us uncover new opportunities to live longer and healthier lives. Ultimately, that is the goal. And I believe that FHIR and the people working in the industry will help us get there in a more efficient manner. And just look at what's happening to the clinical side of FHIR. The original intent was for health systems to make their data available via standard APIs so that Medicare and Medicaid patients could access data and apps of their choice. But that quickly went from Medicare and Medicaid patients to all patients of these health systems. And then not only applications that were for one patient at a time, but for applications that were for entire populations or for provider-facing tools. And then we got all these EHR app galleries, which were providing applications that face doctors and clinicians so that they can interact with their patients. And what we saw was that application developers started creating calculators, alerting tools, and it enabled health systems to really take a different level of control of their data, because now, this one EHR and this other EHR could finally speak with one another, or this one application didn't have to develop against a proprietary method of interacting with the EHR data, but could build once and start deploying across many different organizations. So it's really changed over time. And what we're seeing now with US CDI and FHIR bulk data is that it's making it easier to integrate and connect entirely disparate systems of record. And these new CMS regulations, the claims data is becoming more and more incorporated. And the same sort of trend is likely going to follow suit, where it starts with a small group of patient-facing solutions for Medicaid and Medicare. It'll grow from there to likely the entire population, and it'll grow from there to not just patient-facing apps, but population-level applications. And I think that is why the impact for healthcare IT is just so broad. Everyone here today is providing leverage to every other participant in the care setting. And this technology makes it possible for one doctor to do far more. But if it's not designed well, or with the intents that don't serve the user, but another master, like reporting requirements or other mandated compliance, then obviously technology can get in the way. So I think we all have a duty here to think of the problem holistically and try and arrive at improved solutions over time. And I believe we'll see that over the next few years as more of these requirements fade into the background through automation by technology, by being built on FHIR, especially with regard to the communication between payers and providers, where now both of them are able to speak FHIR. And now that we'll be seeing this data across these systems in the same format, payers and providers will be able to collaborate on patient care in a much more understanding way than they've been able to do so in the past. And this will manifest itself streamlining prior auth, identifying gaps in care, helping guide providers and payers to those decisions that will ultimately improve quality and costs. But like I was saying earlier, the applicability of FHIR is becoming very broad. We see many more participants in the industry, and they're all contributing to the conversation. So the next 3 to 5 years will be extremely exciting. There's much more data that's also becoming part of the equation. This includes sensor data, genomics, pathology, radiology imaging, patient-reported outcomes, and there are FHIR ways to do all of those things. And you know that the other part is that FHIR is not just the API, but it's also providing a data structure. And for those things that are beyond the API, like analytic use cases, we're seeing FHIR still be used as a data model in the format, but research, analytics, machine learning, they all need tabular data. So this which is not the FHIR RESTful interface. So this congress of machine learning with all the data built on FHIR will truly revolutionize the industry, and I believe that that's where some of the most interesting opportunities lie. And the last thing I want to do before introducing our first speaker is give a huge thanks to all the people that have helped set the standards and collect enough critical mass in the industry so that the flame didn't die out, pun intended again. Actually, if you want more FHIR puns, Steve is usually pretty good about that, and he'll be coming up after Alex. And these people are like Graham, Grieve, Ken Mandel, Josh, Dan, Anish, all our friends of the work groups at DaVinci, Karen Alliance, the Fireball Alliance, and many others at HL7. And it is truly a hundreds of people that have contributed in getting us here, and thousands if you're thinking about all the folks that are now working hard to get live or have been working on the provider side previously with FHIR. This is not a small thing anymore, and there's far more to come. So, all right, let's get into this. So, like I mentioned, today we have the best minds talking about FHIR interoperability. We're kicking off with Alex Muggy from CMS and Steve Pozniak from ONC, both of who will be speaking about the regulatory environment. And everyone listening can post questions in our YouTube's live stream as a comment, and the OneUp Health team will help bring that up to those speakers. So if you have any questions around what's being enforced, how it is, when it is, all that stuff, which I know a lot of people have on their minds, please, feel free to ask. And then after that, after the regulatory kickoff, we have a panel with a few health plans speaking on going live with patient access APIs. So a lot of other people on this call are in the same boat. So you'll get a taste of what it is, behind the scenes at other organizations. And then, after that, Kyle and others from the OneUp team will be talking about testing these APIs. Then we'll have a panel of apps moderated by Anish Chopra, who are actually building tools and services on top of these for patient-facing access. Jocelyn and Linnell will be representing a large coalition of health plans from the DaVinci Group, and will provide more insight into that, Gravity and ONC FAST. And then finally, we'll close out the day with payer to provider data sharing via FHIR from Matt Tang and Paul Kamel from Aetna and Oscar Health. And then Joe, our OneUp COO, will be closing us out for the day. So now for the first speaker, Alex Muggy, who was here at VHC last year. Welcome back, Alex. Alex is the Deputy Chief Health Information Officer and Director of Health Informatics and the Interoperability Group at CMS, where she and her team have led the agency's interoperability and health IT efforts under the office since 2018. And basically their mission is to promote the secure access and exchange of electronic health information to support informed decision-making and make us, create a more efficient healthcare system. She's been with CMS since 2010, the whole time focused on healthcare IT. And I don't know if we could have had a more appropriate person to be kicking off our event. So Alex, please go ahead and take it away.
Thanks so much, Ricky. Let me get my slides shared here so that y'all have something more exciting to look at than me. All right, hopefully y'all can see the slides now.
Yep.
All right, great. And let me just make sure I got the controls for them. Okay, so thank you for that intro. So again, I'm Alex Muggy, I'm a Director and Deputy Chief Health Informatics Officer at CMS. And I have a fantastic team supporting me at CMS. So I actually wanted to start the presentation by, before diving into the policies, by talking a little bit about what my team does and the folks that are responsible for the policies that you are going to hear about a little bit more today. So the Health Informatics and Interoperability Group believes in promoting the secure exchange, access, and use of electronic health information to support better informed decision-making and a more efficient healthcare system. We envision a secure, connected healthcare system that empowers patients and their providers to access and use electronic health information to make better informed and more efficient decisions. We are a team that is very passionate about data exchange and the value that it can bring to all aspects of healthcare. So if you want improved quality of care, there's an interoperability use case for that, and we really believe that. If you want price transparency, there's an interoperability use case for that too. So we are very passionate. We believe that interoperability is a critical function in healthcare and is going to be the future of healthcare. But what does that mean in practical terms? In practical terms, that means that we oversee the interoperability and health IT efforts at CMS. We work across the many programs and stakeholders that CMS regulates. And we use that enterprise view that we have to identify opportunities and to work with our partners to drive interoperability. So if you have any idea of the breadth and scope that of the stakeholders that CMS regulates, you can really understand what that means for interoperability. We really can connect with so many stakeholders, and we really try to use the programs and the policy levers that we have to engage stakeholders in interoperability and data exchange. So we also work with our other federal partners like Steve at ONC to advance interoperability policy and strategy. And we use those relationships to try to find ways that we can increase efficiencies by collaborating across agencies and across those programs. So it's a great body of work. Again, we really believe this is the future of healthcare, and that's why we think this is just so critically important. So much has happened in the last 5 years, leading this drive to interoperability, and the use of application programming interfaces or APIs in healthcare has certainly accelerated the interoperability discussion. The CMS and ONC interoperability rules played a huge part in that drive and have really stirred up the conversation in the last few years. So this slide is really just a list of the policies from the CMS interoperability rules. Or rule, I should say. Not all of the policies that were included in the CMS interoperability and patient access rule used APIs or required the use of APIs, but the rule really puts a heavy emphasis on the use of the FHIR standard. And using that standard is critical to implementing several of these APIs into the future of this interoperability. So why did we use it? Why did we require the standard? So using a standard imposes a consistent representation of data, even if the data is sourced from different origination points. And this promotes the ability to exchange and use healthcare data. And I put a heavy emphasis on that word use because simply sending data back and forth isn't enough to achieve interoperability. The data must arrive in a format that can be used by a recipient and essentially turned from that data to information, usable information that would allow patients and providers and caregivers in healthcare to take that information and make sense of it and use it for their decision making. FHIR as a standard is specifically designed to support this kind of information sharing. And even though FHIR is still relatively young standard, it has gained significant traction in industry because of the variety of uses and the incredible adaptability of its resources. And I'm trying to come up with some good FHIR puns here, but maybe I should leave that to Steve Posnack because to the point made earlier, he's really a champ at that. So maybe I'll leave that for him. But there are some great FHIR puns out there that we could throw around. So we at CMS and in partnership with our colleagues at ONC have been really looking at FHIR as an opportunity to align on this single open source standard that is adaptable to the many programs and the many needs that we have in healthcare. As I mentioned, the work that my team does across CMS programs has a huge scope and works with many different stakeholders. And FHIR is adaptable to all of those programs and all the needs that we have there, and is continuing to evolve. And that is why it is such a useful standard in this space. And CMS has been looking at FHIR for years, but it isn't until the last few years that we really started to integrate the FHIR standard into our regulations and even into our own operations for Medicare fee-for-service. Go on to this next slide. Some of you may have seen this timeline slide before. It is hard to believe how far we've come in implementing the CMS Interoperability and Patient Access Final Rule. This rule has gotten a lot of attention over the last 2 years, and we're finally approaching the first implementation deadline for payers. So the first requirement for payers impacted by this rule is to implement the Patient Access API and Provider Directory API. These policies were originally scheduled to be required by January 1, 2021. But given the COVID public health emergency, we did announce at the time that we finalized the rule, we announced a 6-month enforcement discretion and stated that we would not enforce these policies until July 1st of 2021, which is now exactly 1 week away. Actually, I looked at the calendar today and was shocked to see that we have 1 week left before these requirements are in place. So this is the first time, this July 1st deadline is the first policy, the first time that CMS is really regulating the use of interoperability standards for payers. And when I say payers, we are talking about the Medicare Advantage organizations, Medicaid and CHIP fee-for-service, as well as Medicaid and CHIP managed care, and the qualified health plans on the federally facilitated exchanges. So it's quite a few payers. And while we know that this does not cover all payers, and then by extension, this does not cover all patients, we believe this is a significant step towards encouraging payers and their large parent organizations in the use of FHIR-based APIs for data exchange and interoperability. So while these policies themselves may not require those parent organizations, those larger payers, to roll out these policies to all of their lines of business, we would certainly hope that payers will choose to roll out these APIs to all of their lines of business and not just the ones that are impacted by these regulations and the ones that I just listed above. So I'm spending a lot of time talking about how this is the first time that we're regulating payers, and you may be asking why this is so important. And this rule really represents a shift away from our historic focus on only the interoperability of EHRs and their use by clinicians and hospitals. You know, historically, CMS and ONC and federal programs have spent a significant amount of effort on EHR use and in supporting interoperability. But this is the first time that we're going to include interoperability for payers. And that really brings a whole nother stakeholder into this interoperability field. This really helps to engage the payers in the world of data exchange and moving data with a patient, as opposed to accumulating that data in silos. Payers have so much data on their patients. They have contracted relationships with patients for 1 to many years, and the amount of data they can accumulate is extremely valuable to patients. So keeping that data in a silo just no longer makes sense, particularly when we have the technology available to share that data so easily. So we're really optimistic about the July 1 implementations and the rollout of these APIs for patients, because we believe this is the first step for those payers to take the data they've been accumulating and really make use of that for improvement, not just in their own operations, but for patients at large and patients on the whole in the healthcare industry. The next deadline that you see on the screen and where you are with the UR here, the next deadline following that is also a deadline for payers, and that is on January 1, 2022. And that is the deadline to initiate the payer-to-payer data exchange. And as the title of this presentation implies, this is where we're going to focus for the next couple of slides. So let's go to that next slide. So to describe the payer-to-payer policy, I'm going to quote directly from the rule itself. So we believe patients should have the ability to move from payer to payer, provider to provider, and have both their clinical and administrative information travel with them throughout their journey. So this policy really gets at our goal of getting data flowing and encouraging industry to explore ways for patients to bring their data with them as they navigate their healthcare journey. So when you think about what that means to you personally, if you are a patient, we're all patients, to be clear. Everyone will need healthcare services at some point in their life. So I will speak of myself as a patient, knowing that I will be changing health plans in January. It's really comforting to me to know that my data will flow with me. And I hope that you feel the same, knowing that your data flows with you and you'll continue to have access to that data regardless of where your healthcare journey takes you. So many of us may have let a few appointments lapse during the COVID public health crisis or a public health emergency. You may not have gone to your annual physical, and coming up soon, you may decide that it's time for you to go and see that clinician. And if you've forgotten when that appointment is, I bet your payer knows. They have a claim for the last time that you went in for an annual physical. So you'd be able to locate that information easily, but only if you have access to that information as you continue to navigate your healthcare journey and continue down this path of having the flexibility of going from payer to payer and provider to provider. So we believe that patients should really be able to take all that information with them. So what does this actually mean in terms of the requirements? So the effective date is, as I said, January 1st, 2022. The payers that are impacted by this particular policy are the Medicare Advantage organizations, Medicaid managed care plans, the CHIP managed care entities, and qualified health plans on the federally facilitated exchanges. What is noticeably absent from this list is the Medicaid and CHIP fee-for-service programs. And while CMS did not require them to take part in this payer-to-payer exchange at this time, we did send a letter to the states encouraging them to take part. That letter is available on our website, which I'll give you the link to a little bit later. But this letter really encouraged the states to take part in this payer-to-payer data exchange because we believe, again, that patients should be able to bring their data with them regardless of what program they're participating in or how they get their healthcare coverage. So that is just a critical point to make. So what is this going to do for patients? I think I said this a couple of different ways, but the way we've articulated here on the screen is that it really will help them to create this cumulative health record at their current payer. So again, you can change payers, but you'll still have that health information with you. It can also facilitate informed decision-making, efficient care, and ultimately lead to better health outcomes. So all things that we strive for in healthcare policy. So let's go to the next slide here. So this slide highlights an implementation guide. So to be clear, this policy provision did not require the use of an API, but it does require payers to exchange data between one another at the patient's request. This policy was very clear on its intent to have the data follow the patient. However, we have heard that in some cases, we were not specific enough in the mechanism for data exchange by not requiring an API for this data exchange. We did encourage the use of an API. Again, we did not require it for January 1, 2022. So we understand that we've heard that this is challenging, which is why we chose to address this policy again in the CMS interoperability and prior authorization proposed rule, which was published last December. I'm going to talk more about that in a moment, so I'm just going to stick a pin in that for a second, but I did want to highlight that as we're talking about this slide, so keep it in the back of your mind. So while we did not require the use of an API for this upcoming January 1st deadline, and we did not specify any specific implementations, we did point to and we continue to encourage the use of an API, as well as several implementation guides that support the implementation of a payer-to-payer data exchange. So for payer-to-payer data exchange, we encourage the use of the HL7 FHIR Consumer-Directed Payer Data Exchange, or the Karen for Blue Button implementation guide, the Da Vinci Payer Coverage Decision Exchange implementation guide, the DaVinci Payer Data Exchange PDEX implementation guide and the DaVinci Payer Data Exchange PDEX formulary implementation guide. So these all support an HL7 FHIR API and all support that interoperability for the data exchange between payers. And together, these IGs will provide technical insight that can help payers be compliant with the requirements of the interoperability rule, should they choose to implement that using an API, which may be a very efficient way for most payers to implement this. I'm going to go to our next slide here. There we go. This slide represents our roadmap to interoperability and demonstrates a few of our key focus areas. So you'll see that we have highlighted patient access, connecting healthcare through data exchange, and technology and standards. And each of these focus areas is critical to keep our momentum going. And in the first interoperability rule, we put a very heavy focus on the patient aspect piece. And patient access is a critical priority. But to truly get to healthcare data exchange and get to a point that it can benefit patients with better outcomes, and to truly achieve that interoperability that we so need in our healthcare system, we also have to ensure that data is flowing to more than just the patient. We have to ensure that all providers, payers, caregivers, and others have access to the data to help them make the best care decisions for their patients. So as I mentioned on the last slide, back in December, we released the second interoperability rule, the CMS Interoperability and Prior Authorization Proposed Rule. This proposed rule takes our journey beyond patient access and puts a heavy focus on the broader challenges of healthcare data exchange. The proposed rule expanded the policies of the first CMS interoperability rule, and it introduced new provisions that would expand the use of application programming interfaces, or APIs, as well as streamline the prior authorization process for CMS regulated payers. More specifically, this proposed rule really built upon the policies for the payer-to-payer data exchange by proposing to require the exchange happen through a FHIR-based API, and specifically using the implementation guides that we covered on that last slide. It also proposed a more comprehensive data exchange for patients that would include claims and encounter information, as well as prior authorization decisions, in addition to the US CDI or the more clinical data that we had finalized in the first interoperability rule. So, I do want to be clear, though, and I should be very clear on this point. This rule has not been finalized, and it has no impact on the requirements for January 1, 2022. So those of you implementing the deadlines for January 1, 2022, please remember that only the requirements of the first interoperability rules apply at this point in time. The other rule is still a proposed rule and has not been finalized. So let's go, I think, to this. This is my last slide before sharing some resources with you. So I just wanted to put up this slide to have a little discussion of what's next. So CMS will continue to build on our roadmap and work to identify opportunities to drive interoperable data exchange. But we also believe the industry has a significant role to play to further the data exchange through innovation. So, apologies, I think I skipped over that slide. Okay, let's go back to it. So we believe the industry has a significant role to play here. People in general and patients in general have much higher expectations for technology in their daily lives than they did 10 years ago. For example, you don't go to a bank anymore. You do your banking on your phone. You don't call a restaurant to make a reservation or call a cab. You do everything from your phone using an API. So why wouldn't we have the same expectations in healthcare? We as patients are going to have those high expectations because we've gotten so used to them in the other aspects of our life. These rules that CMS and ONC have put out have helped to align industry on a common direction for the standards that will help that technology that will ultimately get healthcare to that same place that we see for banking and other conveniences that we have in our lives. But they really should be looked at as a floor or a baseline for what industry can do to support patients in this space. This is, if you haven't caught on to it, my call to action portion of my presentation, where we're really looking to you in industry to help take these rules and run with it. And, you know, while regulation is one way to keep the conversation going, we want to always ensure that regulation is acting as a catalyst for this innovation and is never stifling in industry advancement. So this is where industry really holds the key to drive change. And we need industry to step in and make those patient applications and services and meet the patient where they are and use this data, use this information to support patients with better patient care. So I'm going to leave you with that call to action, and I'll put up on the screen a slide that has some of our best resources for getting more information. So our website is available for you to take a look at the work that our team does and the policies of this rule. We've also recently posted a lengthy list of FAQs that's sorted by category, so it's a little bit easier to search. When I say lengthy, don't be intimidated. But that list of FAQs was posted about a month or so ago, and then we recently posted an update to include more FAQs on the payer-to-payer data exchange specifically. So I highly recommend that if folks have questions, they take a look at those FAQs specifically. And then if your question is not answered, or if you have further questions, you can always email us at the email address that is here on the screen. And I know I'm going to be here for questions for a few more minutes, but I strongly encourage folks who have additional questions or want to follow up separately to take a look at that email address, and we will follow up with you from there. So from that, we'll open it up to the Q&A portion of today's call. And thank you all for letting me join and letting me present to you here today.
Yeah, thanks a lot, Alex. This is great to have you here again. I think there are a number of questions that we've gotten from the group. And Nolan, were you going to ask them, or should I go ahead and do that?
Yeah, why don't you go, Ricky? You're talking on a roll here. So.
Yes. So I think, one of the big things is like with, ONC, there are rules that were initially mandated for the Medicare, Medicaid population, and they were, I guess, health plans and health systems expanded that access to the general population. Do you think, or when will these patient access rules be applicable to all patients beyond the government managed care population?
Yeah, so that's a super great question. And I guess the challenge there, at least in terms of regulating something like that, is that CMS does not have the authority to require this of some of the commercial health plans. So in order to regulate the broader plans, it's a much bigger process that we just don't have the authority to do. So I think I touched on it at one point during the presentation, and I'll just really specifically say it again here. We are regulating a good portion of the health plans out there, and at least some of the lines of business of those health plans. Many of these plans are larger and have other lines of business that include some of the commercial or the non-regulated plans. And we would really strongly encourage those payers to make these policies, these APIs available to all of their patients, regardless of which line of business they're covered through. These are APIs that provide patients just better insight to their care, help them to make more informed decisions, and ultimately have just better control over their healthcare. So it would be really beneficial not only to the patient, but to the payers to make the information available, because it allows their patients to take better care of themselves and ultimately, hopefully improve health outcomes, which is a win-win for payers and patients alike. So yeah, we would strongly encourage folks to roll them out, but to the questioner's main point, we cannot at this point require them.
Yeah, thank you for that, Alex. Now, one other thing that is on the minds of many of the health plans is, again, going back from the ONC side, a lot of the regulation dates for patient access for clinical data from providers were pushed months, beyond what they were originally stated as. Is there any notion of that happening here with the CMS regulations for payers? And then how are you planning on enforcing, or maybe, giving some sort of grace period to those plans that don't meet the deadline?
Sure. So So as I mentioned, we did provide the 6 months of enforcement discretion for the patient access and provider directory APIs, and those are required to be implemented by July 1st. We did not offer any sort of enforcement discretion for the payer-to-payer data exchange policy. We believe that January 1st is a realistic deadline, and so that is what we are sticking to at this point. In terms of the compliance portion of the question, you know, if I didn't make it clear enough, I think I probably said it like 10 times. So I would try to think of different words, but the intent of these policies is really truly to ensure that patients have access to their information. It's not intended to penalize anyone. You know, that is not our goal. Our goal is truly to work with the payers to ensure that they can meet these deadlines and make the information available to patients. So with that in mind, there is, of course, also a compliance aspect, as these are requirements. So we will be monitoring compliance coming July 1st and checking with the various health plans to ensure that their APIs are available and meeting the requirements of the rule. That said, if they are not, I understand now it varies by program. So just to be clear, if you've got a Medicare Advantage plan versus a qualified health plan or a Medicaid state, you know, it's going to be a different process depending on which program you participate. But the general idea is that if you are not in compliance, you will need to work with that program on a compliance plan, a plan to come into compliance over some period of time. I'm sure that the elements of those plans will vary, and the consequences of not meeting those plans will also vary by program. But you know, we really are intending to work with payers to ensure that they ultimately reach compliance and that patients have the data that they so deserve.
Terrific. Thanks, Alexandra. There's a question that just came in, which I've actually heard a couple times in the market, so I'd be interested in your feedback on this one. It's that if plans opt to send data in digital formats for this payer-to-payer regulation, if they opt to send data in digital formats that are proprietary or overly complicated, which creates some burden on the receiving plan, are the receiving plans able to push back? Are there any other provisions that kick in? Anything sort of in that direction?
Yes, so you only have to receive, or you only have to accept the data if you're able to accept it, and you only have to send the data on in the format that it was received. So we're not asking for payers to receive data in the forms of, you know, proprietary forms or even paper forms, PDFs or emails or faxes or any of those things. We're not going to ask you to convert that to another format and send it forward. You only have to receive the data and send it forward in that form and format. If you're unable to receive the data from another payer because they are doing something that I don't remember the words you used to describe it, but overly complex or proprietary format, you know, I would imagine that would be, you know, impossible for a payer to receive and would need to request the data in a different format. So you know, ideally you would not say, we're not taking this patient data, but would work with the other payer to get it in a different format and make it available.
Got it. That makes sense. And maybe building on that question, I guess this would be asking you to speculate a little bit, perhaps, but do you have any sense of what percentage of payers you foresee using the same FHIR API infrastructure for payer-to-payer that they've used for patient access?
So that I would actually love to have that answer myself. I don't have an idea or a guess, but you know, we do believe that that's probably the simplest way for the payers, if you're already implementing the patient access API, is to, you know, perpetuate that same form of data exchange for payer to payer. So I would anticipate, just from a logical sense, that would make sense, but I don't have a number. If anyone out there is doing that investigation, we would be very interested to hear your feedback and what you find out. So.
Terrific. This other question here, it's a little loaded here, so there's a big, you can take this probably in a couple of different directions. You know, generally, the healthcare industry avoids providing access to data, you know, really wherever or whenever possible. And so the question is how, I think, by the way, there's a clear acknowledgement that all of the tremendous work you guys are doing is to push beyond that perception. So that's probably the first part of what your answer could be. But the rest of the question is, how do you see this mindset changing, or how would this mindset change going forward? Maybe what are your expectations above and beyond these specific regulations that you guys can enforce?
Sure. Thanks for that question. And you're right, that is a big one. So I think we understand that there is a tendency to hold on to the data because there's this mindset that it's, my data, or I collected it, or by keeping this data, I'm keeping my patients. There's a lot of different reasons, I think, that folks hold on to data and don't see the need for this data sharing. But I think that mindset is becoming very outdated, and folks that are looking at this comprehensively are really seeing that by sharing the data and receiving data from others, we can really get that more comprehensive picture of a patient and of their healthcare, their history, and we can make better healthcare decisions. So I mean that from like a provider perspective, the more information you have on your patient, the better, because you can see if there's going to be, medication interactions, or if they have a history that perhaps they've forgotten to tell you about, but now it's included in the data, and you can ask them about that, and that may play into the diagnosis. Like really for providers having access to that information and helps them to come up with better treatment decisions. For payers, making decisions about, a patient's prior authorizations, and knowing that they've already been through a prior authorization process, 10 times for something, and they clearly still need this service, that can really help them in making informed decisions for that patient care. So really, I think the more future idea is, instead of limiting the flow of information, we need to embrace it and find ways that getting access to that information and sharing that information with others can improve patient health and health care, and can lead to better outcomes, which will ultimately save everyone money and probably a lot of time and effort as well. So I think the mindset just overall needs to change. That's not something that a regulation is going to do. We can't require folks to have a different mindset, but they really, I think, in looking at the future of healthcare, you either embrace it now, or it will probably ultimately be forced upon you later. So really looking at the overall good of the patient. And then I'm sure, with Steve speaking next, he can mention some of the, information blocking work that ONC has done. I mean, in that context, they've really said there is no tolerance for blocking information flow, at least, electronically, and where requested. So there is work to be done, but there is certain things that's just going to be a change in the culture of healthcare, and knowing that we have to be positioned to exchange information and realize the value of exchanging that information, and interoperability is the future. And so hopefully everyone will get on board.
Yeah, really, really well said. I think that line of you can't mandate a change of mindset, or you can't mandate a change of culture, but you can mandate things to influence both of those. And you guys are certainly doing a lot of that. So thank you for that. A couple other questions that have just come in. So one is there a CMS recommended or approved API registry that we need to register our APIs with?
No, there is not. We do not require anyone to register their APIs. There are various services out there that folks are welcome to look into, but it's not a requirement, and we wouldn't be picking one.
Terrific. And I'll do a quick shameless plug just for the work that we're doing here at OneUp Health, especially as it relates to payer. We are, very active in the market, trying to work with all of the health plans, those who are using us and those who are not using us, to build a peer-to-pair API registry and really bring this regulation to life for the marketplace. If a patient needs their data from 5 years back, we'll have to follow the breadcrumbs here. If a patient needs their data from 5 years back from a different payer, however, that data is sent to the new payer using PDFs, will it need to be presented in third-party apps as a PDF document?
So I would encourage you all to take a look at the FAQs, because this is a point that certainly has come up several times, and I don't want to misstate anything here. But like I previously stated, we are not requiring that the data be perpetuated, perpetuated in a different format, I should say. So while the goal is to make the data available to the patients, we're not requiring payers to if they receive a data in a PDF, to translate that into another format. So but again, take a look at the FAQs because we do talk a bit more about that. And if it doesn't answer the exact question or scenario that someone's facing, you can certainly submit the email to our inbox.
Okay, terrific. Our friend Jocelyn Keegan, who's speaking a little later on, I don't know if it was a question, but a plug here, which I'll read for the audience, which is she says that we'd love to hear more about who's reusing too. This is going back to who's reusing the patient access API for payer to payer. They're doing a lot of work to try to aggregate that. And she's saying rightfully that especially with the pended rule, we think the strategic decision is to reuse the patient access API for payer to payer and for provider payer workflows. So davincipmo@pocp.com is an email address there if you'd like to weigh in directly to Jocelyn, and she'll speak later on today. We do have a couple minutes left, Alexandra.
Just give a shout out to Jocelyn and the work that they do. They have a lot of excellent work and resources. So I agree with her there, and sounds like we both are interested in getting the same information. Thanks.
Okay, great. We have a couple minutes left, and Alexandra, thank you for for sitting on the firing line here. I guess picking up the bad puns, but is there a question on as it relates to patient access? Is there an enforcement penalty if a health plan has loaded some but not all of their data, so they're halfway home by a week from today?
Sure. Yeah, that goes along with the compliance discussion. So just again to state, it's not our goal to penalize anybody, but to work with you to make sure that the data is available. If you've got the patient access API in place but it doesn't have all the data available, certainly we'd like to see you come into compliance and get the full scope of data integrated. But we would the program that you're working with will work with you to come up with that compliance plan or timeline and take it from there. So hopefully that answers the question for the inquirer.
Yeah, definitely. I'm going to double back to a question we asked earlier because it feels like a clarification point has come in, and this is asking. Harkening back to the question where someone asked if the data that they receive from another health plan is of proprietary or overcomplicated formats, what are their options? You gave a terrific answer that they're not required to use it. They're required to house it, and they can work proactively with the other health plan to bring in data that they can use should they want that. So the follow-up here is, what recourse does a plan have if another health plan is continually sending bad data or incorrect data or quote unquote substandard data?
Right. So we don't address that specifically in the rule in terms of how the plans would work together in that regard. I guess I will say, as the receiving plan, you are not to be held responsible for the quality of data that you're receiving. So we understand that a patient may say this information is wrong, and you as the new health plan receiving that old data is not responsible for updating or ensuring the accuracy of that data. So that just gets back to the quality portion of this follow-up question. But if you're continuing to have problems with payers, I guess we'd like to hear about it to know if there is something that we can help to address with that. But because it's not something that we specifically regulated in terms of, again, that interaction between the two, it's not really something that I can speak to at this point. But certainly let us know your experiences. I mean, the more we hear from folks and the more that we receive in our inbox, the better informed we are about future policies and how to address these things, or what FAQs might be needed or helpful. So do let us know. Yeah,
there does seem to be that sort of boogeyman mindset out there of what am I going to receive, and so it'll be interesting to watch it happen. Maybe just one or two last questions here. Are there industry efforts you're aware of around how a payer organization will authenticate/verify the identity of other payers? So some type of organizational trust framework, centralized authority, anything that you guys are involved with or a part of?
I know that those conversations are absolutely happening, and we've certainly heard parts of them, but we are not part of a discussion or looking at that for any, particular policy decisions on our end. So that's going to be an industry-led effort, and is certainly ongoing. So I've wonder, I think you've got some other great speakers today who might be able to speak to that some and might have some ideas, because I know that they are participating, and be curious what they have to say. But again, it's not something that we're deeply involved in regulating or participating in.
Okay, terrific. That was a whole lineup of really great questions and answers. So thank you for participating in that. We've 2 minutes left here. Any final plugs, Alexandra, maybe for, again, just to revisit some of the links you have here, some of the resources available, and then you can stop the screen share and we can wrap up.
Yeah, well, just a big thank you to all of you at One Up Health for including us in this event and for allowing us to, use this as an outreach to folks. And I give my call to action to industry. We really think that making this technology available is just the first step, but really seeing how industry takes that and runs with it will really determine how effective all of this data sharing can be, particularly as it comes to patients, because patients will receive data or their information, and they can only make that actionable information if it's in a form and format that they can really use and understand. So I think that that's where industry has a great place to play a role and make patient-facing applications that are super intuitive to patients, and to work on these APIs for payer-to-payer data exchange to help facilitate more data being available to patients. So I think there's just a lot of work that we can continue to do here together, us from a policy and regulatory or alignment standpoint, and industry from that really truly innovative standpoint. So I look forward to seeing what's to come, and look forward to seeing what comes after these upcoming deadlines too.
Awesome. Well, thank you again from everyone at One Up, and please give a big thanks to you and all your colleagues and the peers that you work with in the industry. You guys have brought us to a pretty important moment in history here. So thank you for that. Thanks for the time today, and we'll talk again soon. Okay. All right, I think with that, we will move on to the next speaker. So Steve, good afternoon. Can you hear me?
I can.
All right. So let's see, Steve, we've never had the opportunity to officially meet. So my name is Nolan Kelly. I lead our commercial team here at One Up Health. And I know you caught the end of Alexandra's presentation there. So thank you as well for taking some time out of your busy schedule to meet with everyone who's participating today in the virtual health conference. I'll do a quick bio read and introduction for you, and then I'll hand it over to you. You can do the screen share and talk us through and the materials you have. Sound good?
Sound good.
All right. Okay, thank you. So Steve Posnack serves as Deputy National Coordinator for Health Information Technology. In his role, he advises the National Coordinator, leads the execution of ONC's mission, and represents ONC's interests at a national and an international level. In conjunction with the National Coordinator, Steve oversees ONC's federal coordination, the regulatory policy, public-private initiatives, and then the overall implementation of statutory authorities and requirements, such as those that we're all dealing with here from the 21st Century Cures Act, and the HITECH Act, and more. So really excited for Steve to help to join and help build on a lot of the conversation that we had with Alexandra. And with that, Steve, I assume you can take control and share your slides. We really look forward to what you're going to share today.
All right, all good?
All good, thank you.
Super. We've only been doing this for over a year now at this point. So very much appreciate the introduction. Thanks, Nolan. Thanks for having me today. It's actually a privilege to follow Alex. She and I do a lot of work together, and our teams respectively, because it's not just us two that run around like crazy trying to set health IT and interoperability policy. But as was noted, I serve as our Deputy National Coordinator, which means I get to do all the stuff that the National Coordinator doesn't want to do. And equally, as many of you know, I have a bit of a reputation for fire puns, so I've tried to sprinkle a few in there. My mom sent me a book of dad jokes this year for Father's Day, which I guess just continues to perpetuate that They will be cheesy. They will be cheesy, and they will make you groan. But I don't want to disappoint. So let's dive right in. And first, I wanted to just cover a brief agenda for today. I'm going to go super quick through ONC and our work and what we do, in case you aren't too familiar with the office. Talk a little bit about interoperability and the Cures Act and the rulemaking. Obviously, we're a federal agency. We go through regulatory related activities. And so there's lots here related to the work that you all may be involved in, and for everybody attending today that you should be aware of. And then obviously what's on fire, which is quite a bit, and I'll cover that in a little bit more detail too. All right, so very quickly, full name of the office is the Office of the National Coordinator for Health Information Technology. We are a staff division in the Department of Health and Human Services. So we report up in kind of the umbrella of the Office of the Secretary. Alex, obviously from the Centers for Medicare and Medicaid Services, is what's called an OPTIV in HHS speak. So that's CDC, CMS, FDA, the bigger operating agencies in HHS. We like to call them OPTIVs. We were created under an executive order, which means as administrations change, they do change executive orders from time to time and rescind them from time to time. And so importantly for us, we were codified in law by Congress as part of the Recovery Act, which is, you may know in the health IT side of things as the HITECH Act, and that was a part of the larger Recovery Act. So in 2009, we were codified in law. We were given specific authorities by Congress to execute, and that included the $2 billion worth of infrastructure-related spending, coordination with CMS on the EHR incentive programs, Medicare and Medicaid side. That included the certification program that ONC now administers and the standards and certification criteria that we adopt through rulemaking. Fast forward to the end of 2016, right at the end of the Obama administration, there's a widely bipartisan law passed called the 21st Century Cures Act. And while it had a number of other advanced research, scientific, precision medicine-oriented components to the bill, it also included new authorities and upgrades to our executive branch leadership activities from an ONC perspective. And I'm going to talk to you a little bit about some of those as I go through my presentation. When you think about ONC, we really boil down our activities and our work into kind of a 3+1 framework. So we work on standards, and that's actively engaged with the community at large. So across the landscape of standard development organizations, we principally administer the ONC Health IT certification program, as the name might suggest. That is a core duty and responsibility that Congress has charged us to do and engage in. And then the third area of activity for us is around health information exchange. And so that's working at the local, state, federal level. It's working across national networks, regional networks, different jurisdictions, all the way down to that N of one, where you as an individual are seeking to get access to your information. That's an exchange that we also facilitate work and do work around from a health IT standard certification and in certain cases policy related activities as well. Then the other magic power that we have, as our middle name suggests, is that we do coordination. So there's lots of work that we do across the executive branch in terms of federal coordination. I'll talk a little bit more about that with respect to our work on FHIR. And then equally, certainly the past year has been an area where we have engaged with state and public health and the public at large related to the COVID response, doing some data detective work, figuring out where standards aren't necessarily meeting all the business needs, and then bringing that feedback back into the communities that they may be appropriate. And so all of that is really for us toward two specific objectives: advancing the use of health IT capabilities and establish expectations for data sharing. And so again, those are implemented across a wide range of policies, programs, and other activities in which we engage. So a few things that I wanted to call out here. I normally kind of save this slide for the end of and here's a bunch of other stuff that you may want to know. One thing I wanted to call out right at the top, we did receive some new funding through the recent ARP, the American Rescue Plan, for a new workforce program. And so we will be launching, and the funding opportunity is available at that website, a public health informatics and technology workforce development program. And so that's an $80 million program that we've received funding for. The funding opportunity announcement is available now on our website with the deadline. And that is really going to help us advance the workforce dynamic, which I think we all know there are not enough of us in health IT to get all the great work that we want to get done. So the more people I can bring in, to be part of the tribe, the better. The next thing I wanted to highlight here is that as we start this decade and as we're kind of emerging out and looking across the horizon, certainly there are regulatory milestones, compliance dates, and other things that are more near term in focus. But we've launched an initiative that we call Health Interoperability Outcomes 2030. So with an eye toward 2030, what are we looking at to achieve? Because of interoperability, we're going to be able to do these things. We're going to be able to have this feel different. And so if you have an idea, an outcome statement, and that's really literally what we're looking for, you can fit it in a tweet. You could actually submit it via Twitter if you'd like, and there's a hashtag Health Interop 2030 that you can use. We're keeping an eye on that. Please let us know. You can go to the website to submit it the old-fashioned way, I guess I should say, or the socially outside the social contract, approach, where just type in your outcome statement. It could be more than one if you are so interested, but we'd really like to get a lot of submissions. So if you could help spread the word about the availability of that, that would be great. The submission period ends as of the end of July. So July 30th, I believe, is the Friday, is going to be the end of the submission period. Also, just for your awareness, there are a number of executive orders that came out from the president right at the beginning of this administration. And one of them that we're focused on right now with our colleagues at CDC is around a data-driven response to the pandemic and future high-consequence public health threats. And so we had a hearing recently among the Health IT Advisory Committee. That's our federal advisory committee. You can go back and look at the proceedings for the meeting if you're interested in that space. And then a few other things that I just wanted to call to your all's attention that helps drive some of the work and coordination that we do. We have our Federal Health IT Strategic Plan, which is looking at 2020 to 2025. We've got a more research-focused policy and development agenda. And then equally, as part of the 21st Century Cures Act, the first section in Title IV focuses on administrative burdens and regulatory, reducing regulatory and administrative burdens as they relate to health IT and the use of EHRs. So we worked with our colleagues at CMS and others on a strategy for how to approach that, and it includes specific recommendations that you may be interested in checking out too. Okay, so this is a fun part of the slide here. I like to do a little bit of a chronology for how we got to where we are and how timing is really important when it comes to health IT, policy, technology. And you have those windows that open and close. And it's certainly, for those of you that have been in the private sector, you see that market timing opportunity. If you're first mover, maybe you don't catch the wave as, either that second or third mover. So one thing that happened that was really a seminal event at this point in 2007 was the release of the iPhone. And that'll be important as we start to get to the end of the timeline here. But also to note, in health IT history now at this point, Microsoft Health Vault was launched in 2007. And the one thing I like to juxtapose with this is that the last telegram was sent in 2006. And when you think about healthcare and you think about information technology in general, you've got this long tail. And we often talk about this in the standard space where, people are using HL7 version 2 to get a lot of business accomplished today. And there's really no end in sight for its potential use, right? ADT transactions, laboratory results, public health reporting, all of those are different uses where V2 is just baked in to the health IT infrastructure. So going forward, I'm going to kind of populate this really quickly. Excuse me. You've got Google Health, you've got some policy work, you've got the various stages of meaningful use, you've got the first release of FHIR in 2014, and then you start to see a little bit more legislative activity again. So you have the MACRA MIPS related legislative package, you've got the 21st Century Cures Act in 2016, and then you've got the release of FHIR Release 4, right? So in the short window of time between 2014 and 2018, you've got that turn of the crank numerous times to update FHIR. And then you equally have, now that we look at 2007 to 2018, 11 years later, Apple's baked in to iOS 11.3, the Health Records app. And, it's a native application in the iPhone for using FHIR to get access to your health information as an individual. And so you have that kind of 11-year span where Health Vault's come out, Google Health has come and gone, numerous stages of rulemaking, and the release of, kind of an industry-shaking new standard as we have in FHIR. Then you've got our proposed rule that gets released. our final rule, the Federal Health IT Strategic Plan. And up until this point in 2021, we're at a place where we have, part of that rulemaking that we did was around information blocking and the information blocking applicability date that we are now set on. And as I mentioned, that long tail of technology, there are a lot of workflows today, and especially, for those of you that have been in the public health space, you've experienced it, the past year, where we're still using faxing. And the challenge for us, the challenge for the community at large in the health IT space is to have better solutions that, seed or push out the workflows that, are currently appended to or attributed to faxing. If it's easier to do it via fax than it is to use the perhaps more advanced technology that has been deployed in the field, that's a challenge that we have to try to address and figure out, what's going to change that dynamic in the health IT space. And I hate to make, faxing kind of the enemy of our work. It's certainly simple in terms of using that as a quote unquote antiquated technology from a lot of people's perspectives and how that relates to healthcare. But we've got lots of work to do. And I think that gives us, one of those things where when we start to see changes in faxing behavior, that will mean that the other solutions that we've put into place as a market, as an industry, the apps that are being developed for clinical users, the apps that are being developed for individuals and citizens at large, those are going to make a difference in our overall technical kind of ecosystem and deployed infrastructure. Okay, so very quickly, I want to make sure that everyone has a good understanding of the Cures Act final rule. We're going to have a little bit of a focus on some of the FHIR related dimensions that we've included in it as well. One thing to know, the Title IV, as I mentioned, of the 21st Century Cures Act includes two main sections, two main provisions. One is the conditions of maintenance of certification. We often say them separately, and that is only applicable to health IT developers that go through the ONC certification program. So if you're kind of outside that scope or space, still pay attention to those, because there actually are some benefits that you may gain out of the new regulations that are applicable to those health IT developers. The second is related to information blocking, and I'll peel the layers back on that one. The important thing to keep in mind here is that this is new regulatory authority and new scope for information blocking for ONC, and information blocking is a new body of law. So brand new. I know, the law was passed several years ago now, and we've gone through the implementation of the regulatory process. But when it comes to the rubber hitting the road, we are in that place now and fully accepting all feedback, questions, et cetera, through healthit.gov. And I'll give you some resources to get to that in a little bit. One thing also to call to your attention that was adopted as part of that rulemaking is something called the United States Core Data for Interoperability. So that includes all this data here. And really where you see the USCDI come to life is through two particular areas of our certification program. So when it comes to the transitions of care certification requirements, the USCDI is required as the data that would need to be included as part of that payload. And so for transitions of care, we have a requirement that the consolidated CDA, the Summary Care Record Standard, is used for the purposes of certification. And so all this data would need to be, packaged in and included within that for the purposes of compliance with that certification criterion. As we shift over to the API certification criteria that we have, we adopted a new certification criterion as part of our Cures rulemaking that is a secure standards-based API certification requirement, and that includes a reference to FHIR Release 4, Smart App Launch Framework, and a bunch of the other technical specifications that kind of wrap around that all together. But that includes a reference to the US FHIR Core implementation guide and the profiles that would be included therein that reference these data elements in the respective profiles. And so one of the things that you can expect going forward into the next year is going to be greater support for all these data that are included within the USCDI, as we refer to it in acronym speak. Really in a nutshell, super quick, for the conditions of certification, you have a number of these conditions of certification that apply, again, to health IT developers that go through ONC's certification program. There is one in specific on application programming interfaces. And so if you think about all the work that Congress does and the level of detail that they get to, it's kind of unique and impressive that they included an API-specific requirement in legislation. And I don't think we would have seen that, 10, 15 years ago. with respect to healthcare. But here we are. We've got that great opportunity to make the most out of what we've been given from an authority perspective from Congress. And I'll talk to you a little bit more about how we actually implemented that in the regulation. There are other conditions of certification, as I mentioned. So the communications one listed third there, and I'd encourage you to check that one out. That has to do with a number of communications that health IT developers are no longer allowed to prohibit their customers or others from making certain types of communications. And so to say it in a more positive way, healthcare providers, third-party developers, patients, et cetera, are allowed to make certain communications about health IT products that they perhaps may have felt uncomfortable doing in the past, and they now are, as a result of our rule, able to make those communications. Developers can only limit those types of communications in certain situations. And then equally, if you get down to number 5 there, real-world testing. So this is one thing that Congress heard leading up to the legislation, and then subsequently as we implemented the rules, that we wanted to have more transparency and more information about the real-world performance of certified health IT as it's deployed in the field. And so we have certain requirements that health IT developers need to meet now with respect to testing their products in the real world and reporting on that information on an annual basis. So I know this one is a little bit information dense, but wanted to fit all these things on a takeaway slide for you. The 5 fast facts, as I call them, about information blocking. This came out of the law. And so the important thing to keep in mind is Congress defined information blocking. It's a phrase, it has meaning. Congress put specific parameters around it. And then Congress applied the overall compliance paradigm to 3 different types of participants in healthcare. You can see them there in those bullets. The other thing that makes this law unique is that Congress made the law about the data. And that is specific, as we describe it, as quote unquote electronic health information. And so the law doesn't distinguish, it's agnostic, to use kind of that technical jargon here. It's agnostic to whether or not the health IT is ONC certified or not when it comes to electronic health information. And so you may have electronic health information in an ONC certified health IT, EHR typical system, but you may also have electronic health information in other systems that may be part of, one's kind of enterprise or overall information architecture. And in those cases, that electronic health information is still covered by the information blocking law. And so, bottom line there, no matter what technology is used, information blocking would still apply if electronic health information is in scope. The important part of the rule that we put out has to do with the requirements that ONC was given through Congress to clarify the rule's applicability. So we established certain definitions, certain dates for compliance in order to phase out the implementation of the rulemaking. And we also established these things that are called exceptions. And so just like with any other, professional experience, you have the general rule, which is you should share information. And if you can't, then you need a particular exception relative to your ability to continue to comply with the law, with the rules, and their implementation aspects. And so in this case, with respect to information blocking, we've adopted a number of different exceptions, really 2 categories, as I say them colloquially. There are certain exceptions where you just can't share the information full stop. And so the easiest one that I usually pick is you have a system downtime event or some cybersecurity related event, and you have to kind of cut off access to sharing information for a period of time in order to kind of get situated and figure out what's going on. If someone were to request electronic health information at that particular time and they didn't get it, they would potentially be able to point the finger and say, oh, hey, Steve's information blocking. That type of exception that we have in place would allow someone to, avoid the consequences of information blocking, even though that event could have occurred. There would have been an applicable exception for them to meet, and they wouldn't have to worry about any potential oversight or enforcement associated with the information blocking statute. The other thing to mention here is that the oversight and enforcement, as was constructed by Congress, largely falls onto our colleagues at the HHS Office of the Inspector General. And so they're the ones that would be imposing civil monetary penalties of up to $1 million per violation on developers of certified health IT and health information network / health information exchanges. And the other thing that, we don't always talk about in presentations that I've started to include here is that there are 2 different knowledge standards. So for any of you that have gone through law school, you know this in detail. Knowing and having a knowledge standard associated with particular, legal requirements has meaning and is substantive. And so there are two different thresholds associated with information blocking, depending on the actor, as we refer to those three participants, and how they engage in the ecosystem overall. So that's important to know about as well, relative to enforcement and oversight. Okay, so what does this look like on a timeline? We have now passed April 5th, 2021, and that was the applicability date at the bottom half of the slide here for the information blocking provisions. So all those covered actors are expected to begin to comply with the information blocking paradigm as a whole. But the important point here to make everyone aware of is that the scope of data that's subject to or within the scope of information blocking compliance today, up until October 6th of next year, is just the US CDI. So those data elements that I showed you up there are what are in scope for the purposes of information blocking. If it's outside the scope of that data, I would definitely encourage everyone to continue to behave, operate, and comply with the information blocking provisions as they stand. But the overall scope is just limited to US CDI at this point. As you look at the certification program updates, the one thing I would call to your attention there, which is the end of 2022, is that the new FHIR-based APIs need to be rolled out to the community at large. And that's an obligation and a compliance deadline for health IT developers relative, and a bunch of other certification criteria that have updates associated with them. And so I call these comply by dates because it's very possible that if you have a health IT developer that is, just gung-ho, they've developed all of their FHIR Release 4 updates, and they could be rolling out their updates to customers at any time between now and December 31st of 2022. And so they may come into full compliance by, the summer of next year, and that would be great. They do have this deadline by the end of 2022, but you will start to see, especially in 2022, a gradual increase in overall support for the new certified API requirements. Okay, if you need any resources, healthit.gov/curesrule is the place to go right now. Fact sheets, webinars, blog posts, all sorts of other information. If you're interested in information blocking specific nuances, we have an FAQs page now that covers a wide range of topics and frequently asked questions. That gets updated on a periodic basis as well. So I definitely encourage you to check that out. Keeping track of time. All right, still good. So what's on fire? First bad pun. With respect to ONC's work, and this is a deeper dive into our new certification criterion that we've included as part of our Cures rulemaking, we adopted a new FHIR-based API certification criterion. It's read-focused only, and it does reference FHIR Release 4, US Core Implementation Guides, the OAuth and OpenID related specs that are included in Smart App Launch. But the thing that I wanted to focus on here for your attention is it includes required support for an N of 1 type of API data exchange. And then, so that would be, the usual situation where an individual is seeking access to their health information, or if you have a particular clinical app that may be just doing, things on a patient-by-patient basis, as well as support for multiple patients' data. And so that one is covered by the bulk implementation guide that many of you may be familiar with. So the support that is required as part of this new API is both patient and clinical facing. And that's one thing I wanted to make everyone aware of. The API supports, both sides of the house in terms of patient facing and clinical usage apps. That's in contrast to, 5-6 years ago, the first API certification criterion that we put out largely was tied to the meaningful use updates for the view, download, transmit to a third party, and kind of had that API added on as part of that. And that certification criterion was largely deployed into a patient-facing example. That's largely what the Argonaut project focused on as part of its first turn of the crank. And this time around, we want to be very clear that this API certification criterion that we have is in support of both clinical uses and patient-facing uses, as well as single patient in scope, N of 1 and N, greater than some large number. So keep all those things in mind in terms of potential, uses and benefits associated with this new certified API criterion. The other thing I wanted to show, just from a general context and perspective, we've got in the center here, you know, the kind of yoke of my diagram here in the ill pictured blue and yellow here. We have our certification criterion, certification criteria here. The focus, as I mentioned before, for the data that would be accessible is the United States Core Data for Interoperability. And surrounding that, though, as I noted earlier in the conditions and maintenance of certification, we have a number of business practices and other organizational compliance responsibilities that we have now established for health IT developers, in particular relative to how they behave and associate with those certified API capabilities. And so there are things related to transparency and open documentation. There are conditions related to fees, which we know is a friction point. And so for certified APIs, there's a particular fees paradigm that we've laid out in the rulemaking to help make sure that there's the least amount of friction in those different types of market arrangements and the like. And then lastly, we have a set of subconditions around pro-competitiveness and openness. And so those actually apply and have direct benefit to healthcare providers who have the choice of how and what third parties they want to interact with without necessarily needing the permission of their certified health IT developer in order to do that. And so those are some things that we've established as business practices that would be applied as part of the API condition of certification, and that ultimately translate into benefits for healthcare providers and third parties with whom they may want to partner with to interact and use the US CDI available data as those APIs become available. So, you know, one thing that's always helpful is to say, like, well, who's supporting FHIR and what does that look like in the market? And this is a stat that we put together sometime last year, but it still has, you know, some relevance. We are working on a turn of the crank on our data, you know, which we munged together with our colleagues at CMS. But this just gives you a sense of the 10 market leading EHRs. They all support FHIR, and then they're relevant kind of, I call it like attestation share, you know, for those clinicians and hospitals that participate in CMS programs. You know, we have that reported data in terms of the EHR technology that they use, and we're able to kind of make those linkages and look at, you know, for all those health IT developers that are listed there, when they publish the technical documentation, you know, are they referencing FHIR as their API related technology? And so that just gives you a sense, you know, for mostly in the hospital space, you're going to be hard pressed to bump into a hospital that's not deploying FHIR APIs now at this point. Okay, so in terms of our other federal agencies catching fire or being fired up, you know, we have a number, and this is just a sample. Just tried to quickly pull together a few of the places where I knew you might be interested. So, you know, following the great presentation from Alex, CMS is totally on board with FHIR. There's a link to the page where they've got all of their guidance that really focuses on, you know, FHIR-related deployment specifications, the applicability and compliance requirements associated with that. They also have, you know, pilot project, if you're not familiar with it, that focuses on bulk FHIR, and that's the data at the point of care initiative. I would definitely encourage you to check that out. It's kind of a flip in the script on how the bulk, you know, FHIR related data is used in terms of payers providing bulk FHIR back down to providers, as opposed to providers, you know, getting bulk data assembled and then providing it either, you know, to population analytics firm or, you know, to a payer and in that type of exchange. NIH, from a research perspective, has been super on board. They've got this as the first link there. They have a number of FHIR initiatives that they're working on, and some advanced, you know, work that our colleague Clem McDonald is leading through NLM around FHIR, different FHIR related activities associated with research. They did put out a notice around encouraging research related entities to use FHIR, and equally they back that up in a subsequent notice where they reference the United States Core Data for Interoperability as well. So they have been a great partner, our colleagues at NIH, and really been pushing forward. And similarly, our colleagues at the Agency for Research and Quality, Healthcare Research and Quality, AHRQ, they also have FHIR page, and similarly put out another notice to their grantees about using FHIR too. So we're starting to see, and this is a new kind of coordination opportunity for ONC, the cumulative weight, the cumulative investment of different federal agencies and their work in fire. And certainly, DOD, VA, CDC, I should have put up here, in terms of their ECR now and case reporting activities, lots of other federal agency activity going on related to fire. So the feds are definitely fired up, and we're making investments, and we want to make sure, as your national coordinator, that those are coordinated, everybody's lining up on the right version. Other things that would, create friction and confusion in the market. We are working hand in hand with our other federal partners to make sure that everybody's on the same page. So with that, just wanted to wrap things up with what's all this mean? Developers of certified health IT have these new compliance requirements as a result of our rulemaking. Some of them require updates and upgrades to the software and for those things to be delivered to their customers by certain compliance dates, as I noted. There are benefits in that conditions of certification component of our rulemaking. So if you're really focused on what do I need to do for information blocking? What does that mean for our business? I would also encourage you to check out the conditions of certification as well, because there are relevant provisions that even though they may directly apply to health IT developers, it will change the way in which they behave in the market. And then, from an information blocking standpoint, sharing electronic health information is now expected, as the law so set up. And so there are these limited exceptions, but the general rule is sharing information is the kind of the operating mode that everyone's expected to be in. Again, information blocking focuses on data, electronic health information, regardless of the technology in which it may reside, and it applies to that broad range. There's a big definition of healthcare providers that are covered by the law. Developers of certified health IT is obviously a large market space, and you have health information networks and health information exchanges. And as I pointed out, just a couple short months ago, the applicability date kicked in for the information blocking provision. So with that, plenty of time for questions. Appreciate the opportunity to address you. If you want to submit questions relative to our rulemaking or other general topics, you can go to the healthit.gov/feedback form. There's also a place to report information blocking. If you would like to allege a potential claim related to information blocking, there's a way for you to do that as well. And those are things that we are going through now in terms of triaging and referring them to our colleagues at the HHS Office of the Inspector General as well. So with that, thanks for the time, Nolan. And I don't know if do you want me to keep the slides up or just shift back over and we'll do face-to-face?
Keep them up for now, because there's a couple questions here that actually point back to them. Okay. And Steve, that was tremendous. Really glad that we were able to have Alex speak and you speak. You got definitely this Batman and Robin dynamic duo, thing going on there. Yeah. So that was really, really helpful. I'm actually going to ask the first question here, which is, you talked a lot about info blocking and around oversight and enforcement, and that being the responsibility of OIG. This word, just like the phrase info blocking, carries such weight, right, and gravity towards it. And there's two sides to the coin. There are those who have to comply with info blocking, and then those who are trying to be consumers of information or to consume the information. But as much weight as it carries when you have the data, it carries as much weight when you're thinking about who could be info blocking. And it's a little taboo, right, to be this whistleblower mindset. I'm just curious how you see this playing out in the market. Is it going to be all quiet and then OIG is going to do their thing? Do you see organizations sort of stepping up and naming names? How does this go?
Yeah, this is going to be an interesting dynamic in terms of how it plays out, because it's been a while since there's been a brand new overall kind of enforcement and oversight paradigm. I would probably look back to, the HIPAA privacy and security rules as the last policy legal paradigm in healthcare that created kind of a new dynamic for all of the ecosystem to pay attention to. And so the HHS Office of the Inspector General, for those of you that don't follow, the regulatory sites as often as we do, why would you, has put out as part of its regulatory forecast that it hopes to issue its final rule associated with its authorities to do civil monetary penalties later this fall. And so that's one of the pieces that, needs to fall into place. We do receive, complaints today related to information blocking. I would encourage you, if you, feel as though something, violates the law as it's been written, to submit them. Part of it is, signal and noise, kind of dynamic, but also the more that we get insight into the types of complaints and allegations that are being raised by stakeholders, that will also help inform, what OIG looks at, as well. And so, they are keeping a close eye on this space. And as they finish up their rulemaking, I think we'll learn a lot through enforcement. Just like any other paradigm, certainly many of you that serve patients and individual access related support, you've seen the initiative by the Office of Civil Rights around enforcing patient access and the patient right of access. And that, over time will change behavior. I think one of the concerns, that we've heard certainly from industry is, before you start slapping everybody with $1 million penalties, like, let's have a better understanding of how all of this works and, what certain things are going to be looked at, especially by our colleagues at OIG relative to information blocking. And that's certainly something that we've heard and, will remain part of the conversation overall.
Awesome. Thank you. Yeah, certainly a fascinating time. Okay, a couple of the questions here we'll grab. Do HIEs fall under the mandate of enabling API access to patients' apps, in parentheses, just like provider APIs?
So unless maybe I should say this generally, HIEs do not have a specific direct mandate to make APIs available for patient, related access. That may be one technological approach that they use if they were to, receive requests to access, exchange, or use electronic health information, pursuant to the information blocking side. And the reason why I separate these things is, like, typically the only health information exchange, if you put it in air quotes, that would go through our certification program would be those typically that would support the direct protocol, because we do have certification requirements around supporting direct. In this case, it would be the health information service provider, technical components that are associated with supporting that protocol. But in terms of if you exist as an HIE, do you have to deploy, FHIR-based API for patient access? There is no direct requirement that be done.
Okay, great. You can take this one wherever you want, but just a broad question of what is the latest update with TEFCA?
Yes, yeah, choose your own adventure. So as in case you haven't heard, our new national coordinator, Dr. Mickey Tripathi, he's been deeply engaged with us since he started, which was, January 20th. And we intend to put out with our cooperative agreement recipient, the recognized coordinating entity, the Sequoia Project, a timeline for TEFCA this summer that will lay out its implementation pathway to give industry a full view of here's when we expect the common agreement to be finalized, and then here's the subsequent kind of execution and implementation pathway for networks that we call qualified health information networks to start signing on to the common agreement. So stay tuned. We often use words in kind of regulatory speak of like imminent or very soon. And I think it kind of falls into that category. So as soon as we, work out a few more details and alignment, make sure that Mickey is fully briefed on the scope and depth of TEFCA, we'll get that timeline out to everyone.
Awesome, thank you. You might want to click back a couple slides because I think you addressed some of this, but the question here is what level of FHIR implementation are each of the listed EHRs actually supporting? If I remember your slides correctly, you have data from the end of 2019, right? Yeah.
Although I guess to answer that question, perhaps the level of depth, for that slide and the data that we kind of crunched the numbers on, largely a lot of those deployments are going to be DSTU2 Fire DSQ2, the Argonaut flavor. Some health IT developers have started to migrate. I'm not sure of all of their deployment, schedules toward Fire Release 4 with the wraparound of, everything else that we've required. The updated implementation guide for the US Fire core profiles, which are going to be Release 4 based. The Smart App Launch Framework, newest guide with the OpenID implementation support as well as the bulk implementation guide support too. And so all of those are aiming toward compliance by December of next year.
Okay. How should organizations start to think about the info blocking rules that are kicking into effect? If that's the stick, and perhaps that's the feeling that it is, what is the carrot that organizations should start with, or how should they think about the carrot side of this?
Yeah, I mean, you have to go back and I think start at where, what prompted congressional action in this area. And so, there at the time leading up to the Cures Act, which was about a 2-year cycle of congressional work between 2014 and 2016, we were actually charged by Congress to issue a report back to Congress on information blocking, kind of assess the landscape, get an understanding of where those friction points were, where there were anti-competitive practices that may be in place in health IT and the healthcare ecosystem that was otherwise impeding information exchange. And so to say it kind of colloquially and a little bit tongue in cheek, if you could forgive me, like the easiest way not to be concerned about information blocking is to share information. And so largely we've been trying to convey when you think about information blocking, it's really when you can't share information. Do you need to really more deeply think about information blocking, because we have those exceptions. And to say the whole thing as a phrase, there are the exceptions to the information blocking kind of enforcement paradigm. And so if you're sharing electronic health information, then you don't need to avail yourselves and kind of look at the exceptions that would be in existence. But in the case where you're unable to share information for a particular reason, or there are the other category of exceptions that we have, which generally govern the back and forth. So Nolan, if you and I were trying to negotiate, how you're going to make data available to me, there is an exception called content and manner that addresses the content of the electronic health information that would be in scope, as well as the manner by which you would make that available to me. And so we have in that exception, which I think is really important to point out, we first allow for the market to negotiate. And so if two market actors, Nolan and I, come to agreement on how he's going to share the information with me, and I'm accepting of the particular costs that he wants to charge me to make that available, then we can do it and just move on. And so long as Nolan follows kind of that paradigm, then the content and manner exception would generally be met. If I'm unaccepting of, for lack of better English, he wants to charge me $10 million to get access to this data element, I'm like, nah, that's not going to happen. Then we move into what's called the alternative manner kind of step through in that exception, where it first starts with, if Nolan has certified health IT and I can use that, to get the data that I was requesting, then that would be, your obligation to make that data available. It starts to move down into, use standards development organization, ANSI accredited standards organization standards, all the way down to, machine readable format. So ultimately, the pathway and the approach for the information blocking, provision in this case is to enable health information to be shared. That's the outcome that we're looking for in all cases, that ultimately electronic health information, moves from point A to point B. Great.
Well, thank you, Steve. I want to be respectful of your time. We've gone a minute over already. Really appreciate your participation today, carving some time out of your busy schedule, especially given where everything sits, these days, and deadlines that are right on the doorstep. So thank you for doing this. You and Alex both came with incredible backdrops, branded backdrops. We'll talk to our marketing team about 2022. And any parting words you want to share?
No, very much appreciate the opportunity to speak with you. I do have a very boring wall behind me, so the virtual background makes me feel like I'm a sports coach or something like that. But thanks everybody. If you have questions, again, go to healthit.gov and submit it into us.
Great. Thanks, Steve. Have a great day.
All right. Thanks.
All right. Moving right along. So we opened with CMS talking about payer to payer, with Steve from ONC giving us a broad view of interoperability. We're going to come perhaps to I guess double click on a little more current events with the patient access rules that everyone's dealing with. We have 3 guests today: Amal Vyas from Cambia Health Solutions, Jeff Strand from Gainwell Technologies, and Jason Teeple from Evernorth Cigna. So thank you guys for joining us. Appreciate it. I'll do a quick introduction just to set the stage of your backgrounds, and then from there, I'd love to hand it over to Amal first, just to share some slides and some materials. We'll then go to Jeff, and then we'll go to Jason, and we'll come back as a group and do some Q&A. Okay. Terrific. So Amal, appreciate you being here. Amal has over 2 decades of experience in enterprise IT with lead roles in strategy, architecture, and implementation, spanning diverse business domains and definitely great depth in healthcare. He represents Cambia and has actively engaged with several payer initiatives and communities to promote the understanding and the adoption of the FHIR standard. So appreciate your expertise and participation, Amal. Jeff Strand is a business solution architect with over 30 years of healthcare industry experience. He's part of the Gainwell Technologies Innovations team, where he helps define modular healthcare solutions that align to the CMS Medicaid information technology architecture and evolving state and federal requirements. Jeff focuses on the intersection of federal regulations and healthcare solutions. And I know very well that Jeff's a busy guy. So thanks for giving us some time today, Jeff. And then Jason Teeple, an interoperability evangelist at Evernorth. Jason focuses on the early adoption and strategies for FHIR within the organization. He's also an active participant in numerous work streams in the Karen and Da Vinci communities. So 3 folks who are really steeped, I think, in what's happening with FHIR transformation and patient access at their organizations, and really looking forward to you guys sharing your perspectives on everything you've been doing for the last number of months, maybe longer, and where you sit today. So Amal, I'll turn it over to you.
Thank you, Nolan. Can you hear me fine?
Yes, you sound terrific.
Awesome. Thank you so much, and welcome everyone. It's a tough act to follow, Alex and Steve, but I'll try. Hopefully you can see my screen.
Yes, you're good.
Awesome. So like I said, this is a tough act to follow, Alex and Steve. Alex has been, at the forefront of this revolution, I should say, in terms of coming up with innovative ways to allow patient consumers to get access to their data. And I also want to kind of acknowledge the leadership of CMS and folks over at the CMS implementation team in basically establishing a path that other payers are just following. And I mean the introduction of the CMS Blue Button 2.0 API that basically, with that, CMS threw the gauntlet, if you will, for other payers to follow, adopt the FHIR interoperable standard, and enable their member consumers to get access to the data through third-party apps of their choice. So very much excited, and with 1 week remaining for the enforcement deadline, I think this is a revolution just waiting to happen, where third-party apps will hopefully enable consumers to get more of their data and really get a 360-degree view of their healthcare journey. And to what Steve said earlier, the clinical data revolution has already happened with the Argonaut and upcoming US core API implementations. The payer side is just coming online here. And I'm really excited that we're meeting the clinical domain in enabling and unlocking the access and the data for consumers. A little bit of an overview, if you will, on what these rules are that we're talking about here. You've probably seen this slide before, and the specific part of the rule that I'm talking about here is the Patient Access API, which had a deadline of 1/1/21 of this year, January 1st of this year, but has an enforcement deadline of 7/1. On the left-hand side, I've got some implementation guides that payers could use, payers subject to the rule could use to basically be compliant with this Patient Access API. The first one is the Karen IG for Blue Button, also known as Consumer Payer Data Exchange, Consumer Directed Payer Data Exchange. The claims and encounters are covered as part of this IG. So any adjudicated claims that reside within a payer's system of record, they can be exposed through this implementation guide through various third-party apps that the member can choose. The other aspect of the Patient Access API is the clinical data described by the US CDI version 1, United States Core Data for Interoperability. And that domain is covered by the PDEX implementation guide, which is really a layer over the US Core implementation guide. And so with the clinical part covered, the remaining part is the drug and formulary, plan coverage and formularies as far as the plan APIs. And that's covered by the DaVinci drug formulary IG implementation guide. And so we have pretty much the entire blueprint for how plans can realize their compliance with Patient Access API. Again, all these IGs use the latest version of FHIR, which is R4, and kind of push the needle on achieving that interoperability, nirvana, as more and more entities adopt the FHIR standard, data exchange becomes easier. And so these are the IGs that are the center of this 7/1 date. The next page kind of talks about what some of the common challenges are, and this is data that we've collected as part of the Connectathon tracks that we've organized with respect to Karen and possibly other implementation guides as well that I've participated in. The main data point that we've observed is that the consumer or consumer app facing APIs is a totally new thing for most of the payers out there. Payers are simply not familiar with this particular area of information technology. That has been our observation. I mean, some payers are obviously out there. They already have existing consumer and consumer app facing APIs, but majority of the payers, this is new to them. And hopefully this rule and then the implementation aspect kind of pushes them to introducing APIs in support of the Patient Access API rule and other APIs beyond the rule as well. But this was definitely something that the payers are learning to kind of get better at. The second challenge is interoperability standards. Payers typically are interested in doing integrations that are tailored or custom based on the specific integration scenario. And so, and again, I don't speak for all the pairs, but most of the pairs I've seen are, end up inadvertently creating one-off flows or silos. And so reusable, common, and open interoperability standards like FHIR are definitely new to those pairs. And so this rule, again, introduces this standard, wonderful standard called FHIR to the pairs, and kind of, again, pushes the envelope in terms of spreading fire, sorry for the pun, within the pair community. So we're very excited about that as well. Some of the other challenges in terms of tactical implementation aspects are distributed systems of record. Several pairs delegate their benefit management functions like pharmacy, vision, oral, resulting in distributed systems of record. And so bringing all this data that resides in the claims system of record, if you will, or clinical, to expose a common patient access API becomes a tricky situation. And so that's a thing that payers are kind of grappling with and trying to figure out certain best practice approaches, whether it's a proxy thing that they want to go for, or a pipeline, a data pipeline. But this is one of the challenging areas for payers. Then there's the area where you're dealing with scenarios where there's other local, state, and or federal rules in play. An example is, keeping track of guardians in the case of child-only accounts. According to the FTC COPPA, a minor is not able to basically exercise individual right of access. The parent or the guardian needs to do that on behalf of the minor. And so these tricky scenarios where, hey, we've got to keep track of the guardian for the child-only accounts, and we might not be doing that by default under our enrollment flows. And so this is basically resulted in payers looking at their other workflows, related workflows, to make sure that they are in compliance with not just the patient access API, but other local, state, and federal rules. So those are some of the high-level payer challenges. Again, nothing that cannot be overcome. These are all part of the growing pains, I should say, as payers become more consumer centric, consumer focused, and help the consumers make informed decisions about their healthcare journey. Last but not the least, I want to quickly point some references. Again, I'm not going to go over all the references here. The final rule guidance page link provides the same information, or most of this information, in detail. I do want to do a quick plug-in for the upcoming CMS Virtual Connectathon organized by HL7, where all the implementation guides that you've heard about that are for 7.1, as well as the peer-to-peer data exchange requirement for 1.1, they're going to be offering tracks at this event. So I welcome folks to kind of join us in making this event a very important journey towards compliance. That's all I had.
Terrific. Thanks, Amal. There's definitely some questions, but we're going to go to the other two, to Jeff and Jason, and then we'll circle back as a panel afterwards. So if you want to stop sharing, Jeff, you can bring up your materials. Great, we can see them.
Great. Is it in full view, full mode?
It is, yes.
Okay, great. Okay, so we've been talking all day about the patient access interoperability, so we know what the goal is. And so I'm Jeff Strand, and I'm with Gainwell Technology, and we play a leading role in the majority of the state Medicaid programs in the nation. And so for us in particular, the challenge here was we have a time-boxed imperative to translate this data and access this Medicaid data in an entirely new way. So as Amal just alluded to, FHIR is a completely new language to almost all of the Medicaid accounts. And we currently have 20 implementation in some level between contract negotiations and in production with published mandates. And due to the timing of that federal mandate, we're stretching our resources quite a bit. So what are some of the critical success factors in this process? And first and foremost is we have a great teaming partner. Gainwell Technology specializes in Medicaid. One of Health specializes in FHIR, and it's the union of that knowledge that was really useful in this program, especially as it came to the data mapping and the translating of that administrative data, which is the first time that FHIR's really taken on administrative data, and creating that outcome is the union of knowledge between FHIR and deep Medicaid knowledge that really helped there. Another critical success factor is reproducible architecture. So this is a platform as a service, which is serverless clouds, leveraging a lot of the cloud native capabilities. We use a templated deployment for a standardized setup. And in some cases, the FHIR environment can be initiated before the account can even open a firewall portal to share the data. Security is wrapped through the fabric of the entire platform, and it's SOC 2 and Type 2 verified. One of the greatest success factors for us in particular was data standardization. So CMS requires all of the Medicaids in the nation to share with them on a monthly basis a set of 8 data files that are really the breadth and width of the information from a Medicaid, and CMS uses that to make data-driven policy decisions as well as to produce some standard reports. And so we leveraged that concept, augmented it with some state-only people. So we used the format of that all the Medicaids were used to as producing this very rich set of data that we would be able to then populate those APIs with. Because of that, once we had done the initial mapping of TMSIS into FHIR, we are able to take an account from initial kickoff, from project kickoff to populated FHIR endpoints in somewhere between 90 and 120 days if it's a straight implementation. Now, most Medicaid systems don't have clinical data, and as such, if they did, and we have some that do, then there's more time necessary for the mapping, translation, ingestion of those particular pieces. Now, we did have a couple of accounts which, for this reason or that reason, couldn't use the TMSIS data. And for them, we had to do a custom extract of the data. We had to do custom mappings. We had to do custom translations. And those took significantly more time because we couldn't leverage that pre-mapping information. And if we would have had to do a custom extract and a custom mapping for each of the Medicaid programs, we would never have had enough resources to begin to meet the time allocated for that. So the data standardization was just huge for us to be able to produce at scale. Another critical success factor is an agile approach. We've talked a couple of times already that everybody is starting with the Karen consumer payer data set. And so this is the core set of data that is required at the base of the record. And so we started there, but then we iteratively layered on more and more of that optional but very valuable data that's available in the TMSIS extracts that is allowable within the FHIR resources. And we could then share those extended maps both with our existing clients and with the new clients as they were coming on board. And so that iterative expansion really helped in the expanding the amount of time it allowed us to complete the complete data. Now, this really showed the value of CMS's goal of leverage and reuse. Again, without the leveraging of the standardized data, we would never have been able to meet our times. But that said, there are challenges, and chief among them for us is privacy. Medicaid for 40 years has prided itself in how good it protects data. Security and privacy are etched into the very DNA of the policies and of the security processes for the whole process. I've been in the industry for 35 years, and every year I take a HIPAA security and privacy set of required training. And as a matter of fact, very few people in the industry actually know that the P in HIPAA is portability and not privacy. So publishing PHI data to be accessed by third-party apps is just a cultural anathema that's really hard to overcome. So we followed CMS's Medicare Blue Button method of when we're registering a person to their longitudinal record, we have them supply data that they will know and that we will be able to verify in the data so that they can self-register for that. And it'll tie to one and only one person. So we do allow for that self-registration authentication. But as was noted, in Medicaid, more frequently than in other health insurance, sometimes child custody plays a role in that. And whether it's in adoption support or whether it is in foster children or child protective services, sometimes the custody of the child will change. And we're currently working with our clients to find a way to have changes in the data itself trigger a revocation of the association between that particular third-party app and that particular record, and then require them to re-authenticate to ensure that they're still having a continuity of care and the right people are accessing it. That's a work in process, right? It's not something that is fully complete yet, but we're working on it. One of the things that may play a role is digital credentials. Companies like ID.me or the Government Service Administration's login.gov are able to generate and create some digital credentials which could play a role in the authentication and logging in of people over time. That said, we did have the vaccine passport discussion recently, and while technically it is possible, there's still some cultural resistance to the digital credentialing of people, so that may play a stronger role and it may not. As has been said here many times, this is a fast evolving specification, and that means that there's going to be constant change in the payer system. In 2019, FHIR 3.0 was prominent. Now it's FHIR 4.0. FHIR 5.0 is already under discussion and under balloting. The Karen Blue Button implementation guide is in its first iteration, and as the payers and as the third-party apps and as the patients interact with it, it'll change. Already there are changes coming that they intend to ballot, but especially over this next year as we actually have that use of it, I'm expecting there will be quite a bit of change there. As has been previously mentioned, there are numerous FHIR accelerator groups, Da Vinci, Argonauts, Karen, the Gravity Group, and they're all expanding the scope and width of the solution so that we'll have new and different uses for this data, which again is going to require us to think carefully about that data security and that data use management and privacy and consent and whatnot. So there's a lot still that we are not fully mature in, and we will evolve in that over the next couple of years. But again, as I said, Medicaid's been doing privacy for 40 years. This is going to be new to a lot of us in terms of how do we still protect that PHI. And as has been mentioned, there are new federal regulations coming that are going to extend this, possibly not even to the patient access realm, but to electronic clinical quality measures, to HEDIS measures, to other kinds of star rating, value-based pricing are going to be other uses of the FHIR standard, which are going to require systems changes from our part. So what's the impact? Full truth in advertising, we're uncertain what percentage of the Medicaid population will actually make use of this patient access opportunity. My own personal opinion is that the most likely use will be on that new patient intake. When the patient goes to the doctor and he says, what are the medications you are on and what was the date of your last mammogram? If you could use your phone as opposed to your memory to answer those kinds of questions, I think the healthcare outcomes would be better. I think that there are going to be, over time, health management opportunities when we combine the Medicare patient data with perhaps wearable information and schedulers and other ways of creating a healthcare management ecosystem. I think that'll be where the highest value will be. One of our current problems is in the data fragmentation, where in Medicaid in particular, members will move from, say, employment-based healthcare to Medicaid and then back again. And even within Medicaid, they may have MC or managed care data, which may be held differently than in your fee-for-service data. So we still have some data fragmentation to work with. We're in the early steps of our journey, but I think it's going to be a journey that will be good for us all. And with that, I'd like to turn it over to Jason.
Thank you very much, Jeff. Hopefully everyone can hear me. All right, excellent. Yeah, so I'm coming from Evernorth, a little bit different perspective from Amal and from Jeff. And the reason why I'm saying that is because we're coming from a perspective of we have a growth by acquisition model for many years. And when you take along that perspective, what happens is you kind of have data across many different parts of your organization. And when you have a regulation that's asking you to bring in qualified health plans, bring in Medicare, Medicaid, you start having your data distributed. But before we even get to that point, one of the things that we had to really do is take a step back and educate. That was the biggest piece of our process, at least early on, was just educating our business partners and then educating our technology partners. And when you go into that level of detail, it takes some time because you're talking about a regulation which has a finite way of being explained. And then you have the perspective of your legal department, which may be a little different than what you may hear from other legal departments. And then you have everyone else's perspective on that regulation, someone who may have read it once or skimmed through it, they'll have their perspective. So it's a lot of, first, let's educate you on what we're trying to accomplish from a regulatory standpoint. Second, let's correct any maybe misnomers that may be out there based on misinterpretations or other kind of run-of-the-mill conversations. And then let's make sure that once we have a good foundation of what we were trying to accomplish, we have to educate you yet again on what's happening with FHIR. And that's one of the pieces that probably took us the longest time, was that we had some teams that were coming into this that didn't necessarily understand what it meant to have FHIR, and that wasn't necessarily a data standard, is a framework. It's a framework because you have your platform, you have your FHIR server, but how are you going to get that FHIR server up and running is one perspective. And then you need to take in the concept of the data. You need to get your data from its native format and whatever repository it lands in or wherever it comes in, and you need to bring it over into a FHIR format. So we had to take the time to educate our technical teams and say, okay, here's what we need you to accomplish for a FHIR server. Here's what we're looking for in terms of functionality. Here's what we need in terms of compliance. And here's what we need from a security standpoint. And once we got that team under control of what we needed to accomplish, the next part was, okay, let's talk to our business teams. Let's talk to our SMEs that understand where this data resides and help them understand what we're trying to accomplish in terms of implementation guides. And that was an interesting topic because a lot of the teams aren't used to coming from the perspective of, hey, here's a document that tells you exactly what we need to accomplish, and here's how you're supposed to accomplish it, and here's what's required versus what's optional versus what's, you have some flexibility in terms of what you need to present. That created some confusion. It also helped create some clarity as well, because when a question came up, well, is this required? We'll just look at the specification, and it will tell you exactly what we need to do. When there's optionality, we need to kind of educate our teams and say, hey, listen, just because it's not required doesn't mean that we shouldn't provide the data. If we have it, we should provide it, especially if it brings value to the data that we're trying to present. So once we kind of get those teams on board, the next part was bringing our security and information people kind of up to speed. As everyone kind of mentioned so far, we are going down a journey of making this data available through APIs. We're not building the user interface. We're not in control of what the user interface looks like. We're also not in control of what we can necessarily expose, right? The regulations tell us what data we have to expose. The regulations tell us how we have to expose the data. And it also, we have some guidance on what we can and cannot do in terms of shutting down access to the data, and getting our security folks on board with the concept of we have to make the data available to a third-party app. We have limitations on what we can and cannot reject. So if an unknown third-party app comes to our table and says, hey, we want access to your data, we can't necessarily turn them down because they don't have brand recognition. We can look at them and say, okay, well, tell us what you're trying to accomplish with this. Let's go through some minor security controls. But at the end of the day, we have to give access to these third-party apps unless they're doing something completely malicious that we can prove, or they're abusing an endpoint. So there's really limitations on what we can handle here. So once we got security folks kind of up to speed and in agreement and understanding what we're trying to accomplish, we had to go back to our business partners yet again and explain to them, we still can't control what the data looks like when it gets out there. We make the data available. We essentially build the pipes. We flood the pipes with some water. And then how that water looks when the third-party app consumes it, that's out of our control. And that was really an interesting conversation, because the business team really wanted to control what the conditions may look like, or what immunizations look like, or how we present a membership card, a member information. And getting them to understand that that's really not our design considerations. We just make the data available. They kind of had to take a step back and say, okay, well, let's make sure then that we are being educational to the third-party developers and making sure they understand what data we're bringing back and what data we can share forward, so that the member has the institutional knowledge of what they're trying to view and what the third-party apps need in order to make the information kind of recognizable. And once we get to all of that, we go back to data mapping yet again, because we have these implementation guides, and we have to now take all that information, take all that knowledge that we just built in terms of what we're trying to accomplish and how we're trying to accomplish it, and get our data mapping teams to source all this information. And sourcing it is just, when you, as I mentioned earlier, growth by acquisition, when you're trying to source all that information, you're now cutting across lines. And when you start cutting across lines, you run into proprietary code sets or proprietary value sets. So there's a lot of translation that happens there. So when you see that the specification says it's an extensible value set, well, that's great, but we have the data, proprietary data set. So that's additional work that the teams have to take on. So there's a lot of kind of back and forth on what can and can't we do? How do we have to present this information? Do we have to do a crosswalk? Do we not have to do a crosswalk? So within the first 6 months of educating, getting teams up to speed, there's a lot of going back and kind of re-educating and saying, okay, well, we can't provide condition information this way because you use all proprietary code sets. It's not going to make any sense to the vendors as they go out there, and it's easily crosswalkable. Why don't we just go back and look at the data and just do a crosswalk to make it kind of uniform in terms of what we're trying to present? The next piece is, once we get the mappers up and going, it's understanding what does the data look like, right? It's testing. Once we have the data in Fire, we get into a Fire server. It's going back and saying, okay, how does this look to the member? How will this look to the consuming app? And that really is kind of the long goal, is understanding what we're trying to accomplish. When we first did a demo to our business teams, they were shocked on how our data looked because we only did a certain set of data. We only did a couple of resources, and we try to explain to them, here's what our mapping looks like. Here's what we think we're seeing. And the business team's like, well, this doesn't make sense. So we had to go back and kind of re-educate and say, okay, well, here's what the specification needs. And there's a compromise with the mapping team saying, okay, well, yes, certain elements are only required and some are optional. But we're hearing now from our SMEs and from our business teams what's missing and why this information doesn't look like it's in proper context. So that's been a lot of what we're trying to accomplish, at least on the Evernorth side, is just combining all these different lines of businesses that we have in different spaces that we had through acquisition, bringing all the information together to make it a seamless experience for the member. And to kind of go backwards, what we did from an architecture perspective is we had to give a whole new perspective to both our business and technical teams. We had to take a view of what does this look like to the member, and showing an app and then showing a member and showing multiple apps. That was new to our technical teams because they're not used to seeing that maybe an external user can come in through a variety of channels and request their information. So we had to show that walkthrough of what does it look like from a new perspective of, we have a new party, right? It's the developers. The developers are essentially acting as our proxy to the members now. So we have a person sitting in the middle of our exchange with the members. So how does that experience look like from a developer? So we had to go from an architecture perspective and walk through our teams what it looks like for a developer, the importance of a developer portal, the importance of the education information, the material, the sandbox, all the information that's available on our developer portal, and give the insight of why we want to do a developer portal and why it will help us in the long run and why it will help developers in the long run. Once we got through that perspective, we go, okay, great. Now we have them up in the sandbox. Now let's show what it looks like for a member. What does it look like for a member? They first have to go find that app. Once they find that app, they have to say, they want to give access to that. So what does that look like? And so showing the perspective of a member going into a third-party app and then getting redirected to the MyCigna login page to give authentication to authenticate and then authorize access to the information. That was a new perspective for both our technical team and really our security team as well, because they didn't understand that we're redirecting and then going back and creating these JA tokens and explaining how the FHIR launch sequence essentially works. So once we got to show all that, we basically show, hey, now you're hitting our FHIR server. Now you can access it within the context of that member that authenticated and authorized and the information that's going to flow. So just to kind of summarize it all up, from an architecture perspective, what we did was we had to educate, we had to inform, we had to go back and re-educate. We had to sit with these teams, sit with our teams and kind of help each team that had a delivery component, help them understand where we're trying to make FHIR available to all these endpoints. And it was just a great opportunity to kind of bring these folks all together, educate, and make it available for, at the end of the day, the patients. So I'll pause there and hand it back over to Nolan.
No, that's great, Jason. Thank you. It's interesting. You guys all had those same themes roll through, your talks of the learnings of, educating the teams of really the hurdle of privacy and security, right? Getting them comfortable with this new world order, putting the portability P back in HIPAA, Jeff, and then that notion of the developer between you and the member, that sort of new paradigm of relationship, Jason, pretty interesting. Are there any lessons that you guys have learned over the last number of months that you can use in the upcoming payer-to-payer implementation? And maybe, Jason, because you're already warmed up, we'll go back to you first.
Yeah, absolutely. I think the importance of having a standard that you can work towards. I didn't understand that payer-to-payer right now is basically saying, get your data out the door through electronic means, but having a standard in which everyone can work towards is going to be the most important piece, and having a repeatable pattern, right? The more that we can reuse what we already have in place in terms from a data perspective and an access perspective, it's great, but we have to understand where our audiences are, right? Now I'm going to be connecting with Amal. Amal wasn't connected with me before. Now we're trying to connect. So we need to make sure that we're sending data the same way and that we can access in a similar pattern, because that's going to be something that we see as important. One of the things I see under the covers that people may not talk about is that when payer-to-payer comes up, And Amal sends me fire. Well, how did he validate his fire? Did he use JCL7? Did he use the IBM? Did he roll his own validator? What happened, right? Because when that data comes in the door, it may not pass through, and we have to have checks in place for that. So that's going to be something I think we're going to have to learn. Predicting that maybe a future kind of impact. Maybe that's jumping ahead here, but I think that's something that we're going to have to take as a lesson learned. What we're trying to do today to get for patient access, we're going to have to consider for pair-to-pair.
A lot of head nodding from Amal. Amal, do you agree with that?
No, I totally agree. I think there's the two major questions out there in terms of peer-to-pair. Number one, it's barely 6 months away in terms of enforcement. And number two, how can we leverage what we're already building, as payers? How can we leverage what we're already building for the patient access API? And I think that's where most of the conversations are kind of going on, and hopefully we will have some consensus given some of the I wouldn't call it gaps, but given some of the I guess high level guidance in the peer-to-peer data exchange rule. How can we get the payer consensus to decide a common for example, format, let's say FHIR, common mechanism for transport, let's say, smart app launch, and those kinds of things. So I'm hoping that there will be some consensus. There's some awesome conversation going on within the Da Vinci circles that I would invite folks to attend if you're not already doing that, where we're talking about a couple of models where this is all gonna, make sense.
Yeah, definitely. In a couple speakers, we'll get into more of the Da Vinci models and show people how they can get invited. And there's some, we'll talk you through that. What would you think, Jeff, I guess for you, like what's been the biggest replicable learning as you guys think about the future?
Well, I think that once we begin to actually use the data, we're going to learn a lot of lessons, right?
Yeah.
We are building to a paper specification that's a trial use implementation guide. The third-party apps are building to a paper specification. It's when that data actually gets together over the next 3 to 6 months that we're going to actually both grow in terms of the data needs and the error checking that's going to be necessary, as well as the use and presentation of that. So I think that the initial people will honestly probably be a little bit disappointed, and they're going to kind of say, is that all there is? And it won't be, but we're going to need some time to actually move the data through the pipes to see it on the screens and whatnot, to build that richness in that the patients will want. So I'm hoping they'll give us a little bit of time to build and mature, because right now we're building to a paper specification. We haven't literally pushed the data through the pipe.
Yeah, great reminder. We're at the beginning of an iterative process for sure. Lots of learnings and lots of collaboration. So thank you guys, Amal, Jeff, and Jason for joining us today, for sharing your experiences. Really appreciate it. And best of luck as we look towards the future here.
Thanks for having us. Thank you.
All right. Take care, guys. Thank you.
Thank you.
All right. So let's see, as we continue the journey here, so we'll focus on patient access getting live. We're going to dive in here now on a next topic of testing patient access and some of the capabilities you have in place and some other tools that are available at your disposal. This next segment's a bit of a home game for us, as we have a couple of my favorite colleagues joining right now, Pat O'Donnell and Kyle Brew. So Pat will lead us off. Pat O'Donnell is on our strategic sales team at OneUp Health, where he focuses on helping health plans on their path towards FHIR adoption and towards regulatory compliance. He's currently focused on helping those health plans with testing and validation programs for their patient access work, for that infrastructure, and for preparing them for the upcoming payer-to-payer regulation. So very topical for all the conversations today. And then following Pat will be Kyle Brew. Kyle's a healthcare technologist with OneUp Health. serves as our head of product for health plans. Prior to joining One Up Health, Kyle was at Deloitte Consulting's technology practice, specialized in solution architecture, technology strategy, and data analytics. Worked with a number of clients, including the Defense Health Agency and a national health plan with its payer-to-provider interoperability strategies. So thank you guys for coming over to the virtual health conference today. Pat, we'll let you go first and kick us off with some of the patient access testing content.
Awesome. Thanks, Nolan. And it looks like you can all hear me. Kyle, can I get a thumbs up real quick? There we go. So that means we're live. Yeah. Like Nolan said, I've been here at One Up Health working with health plans for about the last year. So everywhere since sort of the beginning of this CMS patient access rule and helping them really talk through what these regulations mean, how it's going to affect them, and then what a solution looks like. So now it's nice to see sort of the industry get to a point where I've heard this a handful of times today, so I'm just going to say it again. We do have that deadline coming up next week. So now a lot of our sort of interest in the market is starting to skew towards patient access testing. So for the next 45 minutes, Kyle and I will dive into some of that. And there we go. So we have patient access testing, we have third-party applications, and then obviously questions, like a lot of the conversation has gone so far. So encourage everybody who's watching to throw in some questions you have. You have me, and then Kyle, who's much more technical than me. Freely admit that, who can answer any of those technical questions you all have. So like Nolan said, it is a little bit of a home game. We're going to kick off with patient access, but just want to set sort of the standard, or set an idea of who we are as a company. So in 2017, Ricky, who was nice enough to kick off today's virtual health conference, he began to build a Fire server because he saw this sort of separation where any of the developers who are looking to innovate on clinical data were unable to, or there was a lag time similar to that of the FDA approving a drug. So how do we help all these innovative app developers sort of start to create on top of the healthcare and clinical data that's in the world today? So now you fast forward 4 years now, and we've worked with over 10,000 hospitals and healthcare systems on attesting to meaningful use. And like I said, for the last year, now we're helping almost 40 plus health plans sort of set up these APIs for patient access, now test those APIs, and also look into the future. So what's coming next? Is it payer-to-payer data exchange, which comes up at the end of the year? And is it prior auth, price transparency, things that are coming down the line as well? So we really are Fire. It's all we do. We eat, breathe, and sometimes sleep Fire, depends on which team you are. So we're well versed in the space and love helping the plans who are having a little bit of trouble with it sort of get in a good spot for the upcoming regulations. Through the work we've done, we've worked diligently with a lot of the working groups in the industry. So Karen, Da Vinci, HL7. And what we've seen is through those relationships, we're starting to have more and more conversations about this patient access testing as it becomes the forefront of what a lot of these health plans are thinking of.
Pat, we can't see slides, just so you know, if you're trying to share your screen.
Well, that is too bad. Okay. Here we go. Can you see slides now?
Yes, you're good. Thanks.
Perfect. So here, I'll just move back one slide real quick. And nope. All right.
Yeah, while you're doing this, Pat, I'll just one more thing to chime in and kind of the origin. I think it's been what a difference a year and a couple of months makes. I've got the got to speak at last year's inaugural VHC, which was in the wake of HIMSS getting canceled, the world getting turned a little upside down, and all of us thinking we were going to go home for 2 weeks, turned into I don't know how many months for all of you. But anyway, it's great to kind of get this group back together. And I think one of the key places we played early on as a company was we really helped connect with the EHRs under the meaningful use mandates. And a lot of those run obviously parallel, but preceding these CMS patient access mandate APIs. And so under that meaningful use set of mandates, providers and through them, their EHR providers were required to make available a patient's data via FHIR APIs so that the patient could share that data and be really the owner and steward of their own data and share them with the apps that they chose to trust. And so we connected to at first a handful, a dozen, and now it's thousands of different FHIR endpoints across Cerner, Epic, ECW, Meditech, et cetera. So that's really where we started back a few years ago, was connecting to all of those FHIR endpoints. There was obviously a little bit different, one obvious difference, the clinical data side, but also key difference, it was such a consolidated market where there were, a few EHR vendors captured nearly the entire market as far as market share. And so the payer side, coming from a claims data standpoint, coming from a much less consolidated market from where the data is stored today, and there's other key differences, but we do have that precedent set by the meaningful use mandates, and that's where we really cut our teeth with FHIR and saw that, like Jeff said in the last session, it is a paper standard, and how it gets implemented in practice is never the same the way twice, very rarely. We saw nuances of the way Epic treats observations versus Cerner. We saw nuances in how people interpret the standards. And so that's really where we really got very deep, very fast as far as learning the nuances of FHIR, or what we call kind of dialects of FHIR or FHIR-ish data. And I think that's going to become more important as we think about all of these payers who are coming at this from all sorts of angles, going live next week, hopefully, maybe some a little later. But as they're going live, I think this testing will help start to level the playing field, because I think we really do want apps to have a smooth on-ramp so that they don't need to worry about the custom nuance of a Humana versus a state Medicaid versus a Cigna versus another health plan. In theory, they're all following the same paper standard. In practice, I think we're going to have a little bit of a adjustment period. And I think that's where really testing is one key place to kind of level that in some ways. So yeah, back to you, Pat, but go ahead.
Thanks, Kyle. Like Kyle said, we've been sort of in this odd state for the last year, and it's pretty clear I still haven't figured out Zoom. So we're working on. But I'm sure this point's been sort of beaten to death at this point. But as we all know, that July 1st deadline is coming up next week, where plans are really being enabled to share claims, clinical, and encounter data, as well as formulary via FHIR APIs. You have your provider directory on the same date, and then pair-to-pair data exchange. I mentioned this now because, and I know there's a few sessions coming up after this who will speak to this, but little harmless or shameless plug, we do have a solution for pair-to-pair data exchange, and it's something that we're looking to sort of iterate on as discussions go that way in the next 6 months. So little nugget to think about there. So without draining this slide, and in sort of the spirit of testing, recently CMS released FAQs around testing, and what they essentially what they said was routine testing and monitoring of APIs it's going to be required it's going to be required and suggested going forward. Where that guidance sort of stops is there a recommended approach or recommended app today? And there is not. In the marketplace, we've seen folks like the Inferno app, we've seen Aegis and Touchstone, and then from are from sort of the working groups and Karen and Karen and CAQH. There's other names of apps being thrown around as possibilities there as well. So all of this a long-winded way of saying we are in that field, and we're obviously able to facilitate that testing as a third party. A lot of the health plans I talked to today are using their vendor to do testing. They're doing internal testing. And when I talk to them about sort of a third party apps point of view, where we'll be able to develop a report and give some feedback into what we're seeing, a lot of them either aren't looking at it that way or aren't looking at that as a possibility. So when you start to have that discussion, you see sort of eyes light up and you start to go down a much different path than just, hey, let's have a conversation about connecting. So our testing is live. Obviously, patient access APIs are live today. The provider directory API testing begins 7/1, and then peer-to-peer data exchange testing begins in October, and that's sort of a sliding date as we see where the market evolves. So I throw up this slide, and anybody who's close with this project is probably rolling their eyes and saying, Pat, we know who's being regulated. The point I really want to make here is obviously these 6 groups are under CMS. They're being mandated for the patient access piece. But what we're seeing in the market and what we're seeing with a lot of the health plans that we work with and talk to is they're not only looking at this in the scope of CMS and compliance, they're looking at this as let's either get all of our population on today, so including commercial members and other groups, or sort of taking a stepwise approach where we'll start with CMS, but I think it's a common theme through a lot of the conversations that have been had today. FHIR is the new standard. And why not? We've already built this server. We've already spent this money. Why not really iterate on top of it and make it a meaningful system for our core data sets?
Yeah, and just one thing to add on that, Pat, is just, sure. Yeah, totally. And echoing is yeah, there is checking the box. And I think most are first and foremost concerned with checking that box for next week, July 1st. It's been a anxious period of months leading up. And I think that's a great starting point. But I think to Pat's point, it's investing all this time and energy of all these teams and the data transformation, the authentication pieces, the developer portal, all the pieces that go into this rule. That's really a foundation and a starting point for some of the organizations that we work with that really do want to leverage this internally for their own benefit. Because yes, July 1, the mandate is a member of one of these types of health plans be able to share their data with a third-party application of their choice. But that's just kind of a starting point. There's no limit to what an organization like a health plan like one of these can do with their own data internally once they have sourced data from claims warehouses or clinical HIEs. We've been getting feeds from NextGen, getting observation feeds for some of our customers and other clinical sources, marrying that with the claims data all in a common FHIR format as the standard, as Pat's saying. And that's really where you can start to think of some much more compelling and value adding use cases internally. And so, yes, we totally get the check the box crowd. And I think everyone needs to check the box to get started. But CMS, and you saw this through Alex Mugi earlier, and is really, they have a much broader vision. And we're not done on July 2nd. We're not done next January. It's going to continue to be a journey. And I think those that really embrace that sooner and really kind of jump on board of FHIR and what can I use FHIR for internally for my own population use cases, individual use cases, beyond just compliance. I think those are the organizations that are really going to thrive in the next few years. And so we kind of work across our customer base of payers. We are kind of, it's a spectrum. We see both ends of it, but I think there'll be kind of the bleeding edge leaders, and there'll be the fast followers, and there'll be the more risk averse, want to make sure fire is not going to become a temporary standard, which it definitely won't be in our view. But anyway, so I think that's really, we're seeing all sorts of different reactions, but I think we really want to stress that compliance is a good starting point, but let's also think about fire in its kind of truest value adding sense rather than that.
And that's some that is some good insight, Kyle. Appreciate that. So like I said, there's really a handful of apps that I've seen from the conversations that these health plans are looking at for this patient access testing. That being said, our patient app is really facilitating a lot of our testing capabilities. So we have sort of two tiers, and I'll walk through them. But you have your baseline compliance testing on this page, and then you have a more additional compliance testing that gets a little bit more deep. But like I said, the sort of first step here is connection. So when you're a health plan sort of looking at this, can our patient access APIs be accessed by third-party apps? So what we'll do is we'll essentially start to understand where all those endpoints lie, client ID, secret, and then be able to come in, connect our app, and our reporting, which I'll be able to show you all in a couple slides, is basically a red, yellow, green. So can we do it? Did we find some problems? And then we weren't able to make that connection. And that sort of concept goes through the rest of these as well. The next piece is we're able to authenticate that the APIs to both the member and the developer support, and the developer sort of experiences are up to scale. So like I said, we've been working with developers for about 4 years. So we very much understand industry standards and best practices. So when we go through sort of these workflows, we'll be able to identify some things that you do really well, identify some things that need some work, and be able to provide appropriate feedback on those areas. The third piece here is, and Amol mentioned this in the last session, we'll be able to confirm that your fire data is conformant to the implementation guides that are set out. So and like Kyle had just mentioned, is the fire that we're looking at compliant with those guides? And because fire comes in so many different forms and so much different language, is the project that has been put into place, is that where we need it to be, or are there a few tweaks that need to be made along the way? And then finally, for the baseline piece, implementation of scopes. So if our app says that we're going to pull height and weight from a given health plan, we'll make sure that when we make that API call from the health plan, that we're not pulling something like a lab value, and that when that value comes in and is rendered in our app, that it's something that was intended and that makes sense.
Yeah.
So that's sort of, go on, Kyle.
Yeah, sorry. I was just going to say, yeah, I think the scopes is a critical piece of all this. And I think there's obviously the smart scopes like OpenID, launch patient, fire user, and really making sure that as part of this payer's implementations of this, you need to be very careful that you're implementing scopes the right way, so that when an app, like any app that your members choose, gets authorized, that app gets a token that is scoped down to the minimum necessary. So only scoped to that specific patient that authenticated and authorized, and scoped so that app could not turn around and use that token to get a separate member's data or someone else's data from the server system. And so a few years ago, ONC had a kind of fire security challenge that some of our developers were able to successfully win by hacking other fire servers, where we were able to turn around and use a token we got via OAuth to access any data on the server versus the one we were supposed to. So something that we're definitely very cognizant of, and I think that's one of the more, this is all kind of, it's patient at a time, but you need to be very careful that these apps are getting a patient at a time and also getting read-only access. You don't want these apps being able to, at least to start, being able to write back to your source of truth record. In the future, maybe that changes. Maybe you have an app that you trust enough to do that. But to start, really what's required is a read-only snapshot for that one member at a time. And so Scopes is a really important piece. And I know that Josh Mandel and others in the industry are hard at work as we speak on kind of the next iteration of smart scopes that are going to get even more granular. So today it's things like patient star.read, condition star.read, and it's going to become more and more like a true RBAC or role-based access, where it's going to become create, read, update, delete down to that level across resources. And so there's some drafts out there. And for those that are involved in the Zulip or FireChat community, there's a lot of activity going on there. And I think Scopes will continue to play a critical part with Fire to make sure that we're sharing the information that we need to. And that's part of this testing, is really making sure to start, are you supporting Scopes effectively limiting to one member and read only? And then there's obviously more and more nuance if you support offline access, launch patient, or the other scopes as well.
Like I said at the kickoff, Kyle's a little bit more technical than me, so I'm glad you came along for the ride on that one. So moving into sort of the additional compliance testing, the first bucket here is validating. So essentially, and I said it a moment ago, but Fire comes in a lot of different shapes and sizes. So the data that we pull, we're essentially making sure that it is Fire, and that if we're looking to pull something like a lab value, like I mentioned a little bit earlier, we're making sure that we're not pulling an entire chart and things like that. The next two are load testing. So essentially, when this gets up and running, and when we have thousands of patients in some cases, hundreds of thousands of patients in some cases, start to utilize these APIs, we want to make sure that we can assess performance over time, make sure that those things will hold up with additional usage. And then finally, it's the monitor piece, where essentially a shade of the load testing, but applying metrics to what we're seeing to confirm continuous uptimes and performance. In the last two boxes, from what I've seen from a lot of the payers I speak with, is if you chose a solution that was either built in-house or a little bit more customized based on your specific needs, I see a lot of those health plans really reaching for the load testing and the monitoring of performance, just because they see value in the additional capability and being able to have sort of a third party look at those and provide metrics to them instead of them having to build something. So like I said a little bit earlier, with the baseline and the additional testing options, we essentially have that connection piece. We render data in our app, and then we're able to generate a sample report based on our findings. And like I said, red, yellow, green. So you're doing real well. There's some things you need to work on, and then sort of a failing grade, if you will. And then obviously any comments or things that we find in the process. So when it comes to testing, there's a handful of different things that plans need to consider. Today, with it being before 7.1, in a lot of this data is not in production yet. Which environments are we looking at? And are there architectural differences when it comes to the evaluation of that of those environments? And then also when it comes to data, we've done we're doing some testing in testing environments. We're doing some testing in production environments based on where that plan is in implementation and sort of what they need. I can sort of see a world where in the next 2 weeks, when things are in production, it shifts to more holistically. We're looking at production level data. And then also, really, what data are we expecting to render in the app? And is there a source to compare this against? And then finally, one of the things that we talk to a lot of health plans about is, well, we found you because you're one of the handful of apps that seem to be offering this, one of the handful of apps that or companies that seem to be offering this service. And then how do we integrate the OneUp Health patient access app into sort of our app directory? And that is something we're very open to, and something we're looking to do with most health plans where it makes sense. So that's just about my time on patient access testing. If you would love to engage with us on the patient access testing piece, my email is obviously right there, nice and short, pat@oneup.health, and then you can always reach us through the contact us page on our website. And we can open up the floor to some questions if we have any, Nolan.
I think, yeah, let's head over to Kyle's portion.
Sure.
If we have time and there's relevant questions, I'll grab them.
Sounds good. All right, you can go to the next one, Pat. Yeah, so I think Pat is talking about testing it. But I think one of the big questions that we get asked a lot and is just out there is, if you build it, who's going to come? Who's going to come use this? And what is the volume going to be? What apps are out there? Like Pat said, there's a handful that are more prepared now, and hopefully that number of apps grows over the next 3 to 6 months. I think there are some apps that are a little bit wary of being the guinea pigs and testing all these endpoints and getting into it before they really know who went live on 7.1. Is the data quality there? Is there a whole host of people waiting for 9.1 or later have a waiver to wait a little bit? And so hopefully we'll see the growing trend of apps who will actually be in the hands of your members once you go live. But there are a few I want to highlight, so you can go to the next slide, Pat. And this is all kind of bridging our session towards the next session, which will be with Anish and a few of these apps that I'll highlight briefly, and they'll be kind of speaking from the app's perspective more so. And I think we as OneUp Health, this kind of Pat alluded at the beginning, we're kind of in a unique position where we're both have a patient-facing app that is connected to many clinical EHR endpoints, and now we are one of the first 3 apps connected to Humana's endpoints, one of the first endpoints live in the industry, and we're connecting to others, helping them test their endpoints as we speak. And so we're both that app, but we're also a fire server for dozens of payers as the full end-to-end solution for patient access. So we really, in a way, we're doing our own connectathons all the time, where we're connecting our app to various environments. We will participate in connectathons from both angles, as a server and a client. And that really gives us a good perspective of, we really appreciate, as from a developer standpoint of an app developer, what makes a nice experience, because that really is important, that we want to foster innovation. We want to foster the ability for different apps to come add value. And if they need to do things 345, I think is the number I've heard, of payers under this rule different ways, that's really a painful thing. And some apps just don't have the resources or the time to really do that. And so Karen is one group we've alluded to and been very present throughout this VHC. And they just recently on June 1st released their kind of app registration guide, which I highly encourage all the payers out there. And it's not just for payers, any audience applicable to this rule, to go out and read this. It's a very nice summary in a PDF of where Karen is coming together with its high-level recommendations for this app registration process. And so just kind of some of the highlights, they're definitely pushing having a publicly accessible developer portal versus having to email someone or get on the phone or do something. Developers are kind of much more inclined towards a self-service model, like a developer portal. Having good technical and business documentation, I think, is key. I think that goes hand in hand with the portal. Having developers not have to ask, what's your token URL? What's your authorized URL? What scopes do you support? Where do I get my client ID and secret? There's a lot of basics that can save a lot of back and forth if you just have good documentation. What resources do you support? What are the endpoints? And also just business documentation on kind of what lines of business, what are your different brand names that you want apps to portray? Because not only are apps going to have to render your data, they do also have to allow members or users of their app to search for your health plan. So there's a lot of good work being put out, among them by Jennifer, CEO of One Record, Blumenthal, who's working on what do they want to see in a directory of payers. So there's kind of that side of it as well. I think a sandbox is key. Having a sandbox with good test data, because I think that the app developers really need to know, what is it going to be like once I do actually connect and go live? And having the most realistic set of synthetic test data, the better, because that really helps them develop the best app they can. App registration. So yeah, again, sure, they've gotten the sandbox, they've read the documentation, they've gotten their credentials. How do they actually register? How do they get vetted as an optional kind of CMS recommendation for going live? What's the patient experience like? There's some sections there. And then also just general service level expectations. As a payer, you should be keeping your metadata statement up to date. You should be having support for various issues for developers that they raise. And there should be documentation updates in a timely fashion and just overall uptime. These are all kind of key important parts. So this registration guide has a wealth of information. Can't do it justice in a minute, but I think this is a good step forward as a draft for the industry. Go to the next slide, Pat. Yeah, so a little bit just kind of how we had our onboarding process. We're continuing to fine tune and tweak it, and we're definitely taking some of the feedback from Karen's registration guide that we also provided inputs to heart and updating. But how we think about it is, like I said, we have dozens of payers that we are implementing the patient access solution for. We really do want to provide a single smooth on-ramp for all of our payers to third-party apps. We really do not want, and the apps can't really scale to having to do 30 different security forms, 30 different attestations, answering 30 different sets of questions about everything. So we're using ourselves and our experience in working with these apps in a number of capacities to really have this single, secure, kind of informed on-ramp so that we can vet them. We can see that they have a viable app that can connect to our sandbox that we provide. We load our sandbox with Cynthia-generated Karen and US Core and other implementation guide data so that the apps can actually get a feel for what is this flavor of fire going to look like when they actually connect. And then really just, again, kind of giving them this single on-ramp where we can check, do they attest to the Karen Code of Conduct, leveraging the ONC model privacy notice and other tools to really assess these apps as far as, are they apps that are really trusted, that members should definitely be encouraged to use? Are they apps that are made available to members, but are less, maybe they don't quite follow all the best practices, and that's a different bucket? Or are there apps that pose a direct security threat and therefore do not get production access at all? So those different buckets of apps, but we're really trying to really make this a nice, seamless experience for these apps to have a single throat to choke if anything goes wrong, and anything as they're onboarding, so that they don't need to worry about the nuances of all of these different customers. And I know there's other groups out there like CAQH implementing similar things, and others that are really kind of have a good model to follow. I think Humana is another one that has a great developer portal and onboarding experience as well. So that's a little kind of how we think about it. But like we said, this is all evolving, and I think the industry is also evolving as far as dynamic attestations and other ways of doing this. But for now, we're trying to make it as smooth as we can for the apps that are to come in the next few weeks, get it going live. Yeah, and so a little kind of preview, who are these apps? There's the Karen Alliance, as you might assume, has an app gallery. This includes clinical data as well as claims, so not just payer apps, but a more broader set of apps that are out there. We have our own app gallery of apps that we've worked with over the past few years. And I think one of the great places to look as for an idea of who are the apps that might connect, how many are there. So there's 68 approved apps for CMS Blue Button 2.0 today. And you can go look, there's a link on Medicare.gov of who are those 68 apps today. Quite a few of them have to do with searching for a health plan, but you do get a feel for, you'll start to see some similar names coming between who is a CMS Blue Button app and who's going to be going live with these, because in many ways, Blue Button is the precedent and the standard that CMS set themselves by making Medicare fee-for-service data available via FHIR APIs, and now requiring all these mandated health plans to do the same. So those are a few of the places that you can look for where these apps are going to come from and get a sense for how many that are out there. Go ahead, Pat. I think we're, yeah, and so there's a few slides here on some of these apps. MaxMD is one. You're going to hear from OneRecord and Health Picture on the next session with Anish. There's also BeWell. Apple Health will be coming at some point. And so a number of apps that are been very active at the Connectathon space. For any of those that have been attending, you likely have connected with MaxMD. You've likely connected with some of these other apps. And those are really the kind of early, they're taking the bruises of being a guinea pig and figuring this out. But that's really some of the apps that are out there, as well as the sources I showed on the last slide. So before I open up for questions, I'm just going to show a quick demo to kind of bring this to life a little bit. All right, Pat, I'm going to cut over. All right, so this is our test app, and I'm just going to kind of show, this is our test app connecting to our sandbox that I just mentioned. So this would be like the app's experience in kind of already kind of being registered with our sandbox, already knows the client ID, knows the redirect that I'm requesting. And so here, I'm able to authorize a member. And so in this flow, I'm using, for this kind of demo plan, I'm using some synthetic patients info in order to validate. And so as I enter this, I'm authenticating as this synthetic member that was Cynthia generated. And on doing this, I'm gonna, if I can successfully enter the info, then I'm gonna also associate an email with my information such that I can come back and use this email in future authorizations. And so entering, I'm just using a temp email. I get a code to my email that I can use to kind of confirm this email is associated with my demographics. And then on doing this, I kind of come to this final, by clicking approve, this is that consent language that you're going to see where you all as payers and app developers, there's kind of need to make your members have a informed decision. So give them all the information they need on should they trust this app and what is this app going to have access to do. And let's say the member does agree to do that, that is where they'll get redirected back to the app that they started with. And so this is our test app pulling in FHIR resources for that single patient that I just signed in with. And so I can see this patient's resources. I can see kind of the patient resource, explanation of benefits. And this is all kind of pulled from Karen generated Cynthia EOBs, coverage. You can see other resource types like practitioners that are referenced by those EOBs, as well as some clinical data as well. So we've loaded some US core resources as well for this patient. And each of these, underneath each of these in this test app, you can also get into the actual raw JSON payload. So this is the payload that these apps are going to be consuming. And it's really up to these apps to render this in a more appealing way than raw FHIR. I don't think any member or patient ever needs to or wants to see something like this. They don't need to know what FHIR is or what JSON is or what nested JSON is. They really want a way that they can pull in their payer data, pull in their clinical data, pull in any other sources of data, into one place and really start to add value. And so this app is obviously pretty bare bones. It's just our test app, but you can start to understand that what are the various data that these apps are going to have access to once they've connected. And so this is what we populated in our sandbox. We have a few different test patients. This is one of them, but this gives the app the ability to understand how does that authentication and authorization handoff work? How does the OAuth2 token retrieval work? And then how does the data look once they do have that token for the member? So this is kind of how this is our own test app, but other apps are connecting to our sandbox in order to get that first party view of how this works. So yeah, with that, I think, Nolan, we can open up to any questions there might be. I know we have only 3 minutes left. Sorry.
Yeah, maybe just, no, this is terrific. Maybe just one question, Kyle, is, that demo environment you just walked us through, who would be using that? Like, who's that intended for? What's the intended audience and the intended purpose? If you could just state that quickly.
Yeah, so I mean, first and foremost, with the demo is for developers, app developers that are looking to verify their app can connect and use the OAuth2 process and model to get data. So that's really the intention, is a single sandbox that we can let many app developers interact with simultaneously so that they really can build their apps and are confident when they do go live in production that they've built their app that can handle those processes. The test app I was showing is kind of dual purpose, that we can use that. We use that internally. We use that with our payer customers. We use that just to kind of make sure the lights are on and make sure we can connect to ourselves. But that sandbox is really for app developers, which we're about to hear from in the next session.
Terrific, thank you. There are some other questions here, but we're short on time, and I think you've probably hit on most of you and Pat hit on most of the topics in the slides. So I think we're good. Really appreciate you guys, carving some time and walking through this material for us. So thank you very much. We will let you get on with your day, and we'll head on to the next session.
Great. Thanks all. Good luck in the next
awesome. Thanks,
7 days
everybody.
till 7/1.
Thanks, Kyle. Thanks, Pat. All right. So we'll continue the thread, in terms of the sessions here. I hope you're onto the rhythm, which is, starting with CMS and ONC and payer to payer, moving into the patient access rule, some experiences from the market and some payer customers, and then Pat and Kyle having just talked us through testing of apps and testing of connections and what tools are out there for you. And now we're going to pivot over and talk about the app side of this rule and really all the opportunities that this creates. So we're lucky to be joined by Anish Chopra, Tori Buck, and Jennifer Blumenthal. I'll introduce them quickly, and then I'll hand it over to Anish to drive part of the conversation. So Anish is the president of CareJourney. It's an open data membership service building a trusted, transparent rating system for physicians, networks, facilities, and markets on the move to value. He did serve as the first US CTO, and he authored Innovative State, How New Technologies Can Transform Government. And Anish is joined by Tori Buck, who's Senior Product Manager at Health Data Analytics Institute. It's a Boston-based predictive analytics company focused on pop health and patient health. Tori focuses on predictive analytics for population and patient health, and brings her passion for user engagement to Health Picture, which is an exciting app. It's HDAI's direct-to-consumer health app. And then Jennifer Blumenthal, also with us here on the panel, who's an expert and advocate for data access in the consumer healthcare space. Jennifer is the chair of the Privacy and Security Committee at the Commonwealth Health Alliance, chair of consumer-facing technology at Carequality, and co-founder of OneRecord, a really important app in the space here. So thank you guys for joining us. And Anish, I will hand it your way to help us navigate the conversation today.
Yeah, Nolan, thank you so much. And real excitement to have this session on the eve of 7/1. I just caught the tail end of this, but I assume that's the recurring theme. We're all excited about the go live. What I thought I might do is just maybe set the stage for a couple of items. I don't know if I can quickly share. I've got just a few slides, if that would be possible. to share. You can just give me a thumbs up if you all can see that, if it's coming through.
You're good.
Thank you so much. Obviously, to me, the broader set of rules, it's one thing to talk about the compliance side. How will you deliver? How will you deliver? What will you push forward? I think the message we want to come out with is frankly it's the inverse of that. It's what can we do to help people live better lives? And what are the types of applications that we're going to see coming to market? And obviously, patient applications will be front and center, and we're all eagerly awaiting what will be some of the most high profile and potentially the most widely deployed apps that have been captured by the patients. By the way, forgive the lawnmower on the outside. We're having a fun grass cutting outside, so you'll enjoy that hum in the background. This is my opinion, and I'll set the stage in the following way. There are 5 initiatives where I'm going to be putting a lot of my personal energy to make sure that these applications really operate in the best interests of the American people. And the Biden administration's made it clear that as we come back from the pandemic and we sort of get the economy moving again, there are going to be a number of initiatives that will take front and center. I believe 5 of them will kind of link off of the work we're all doing for not only for 7-1, but more broadly across electronic health record interoperability, as well as the payer side. Number 1, and I think central to this, right now, the governance model for patient-facing applications is mostly of the variety that don't lie to your customer and then you can operate. The Federal Trade Commission today regulates commercial applications if they deceive their customers. Short of that, it's a bit of a Wild West. I'm hoping we're going to get more industry consensus to go beyond what's minimum in terms of protecting the American people and to aspire to a broader vision of what I refer to as a health information fiduciary. Now, the attributes of a health information fiduciary are that they access information on your behalf, run decision support that's in your best interests, and then I hope they compete on making it easier for you to accomplish the things that are going to help you live a better life. There's a mechanism I believe the administration will sort of oversee that will bring more health information fiduciaries to life, and that is the Medicare Direct Contracting Program, which also went live this year in April with a new feature where patients could digitally affirm that this primary care network that might have a mobile app associated, it doesn't require it, but if it does, will be my main point of contact for what will be my fiduciary for managing my care in the Medicare program. I'm excited about this opportunity, and I'm eager to get as many patient-facing applications to raise their hand and say, I wish to be a fiduciary, to go above and beyond, and I'd like to connect to those physician networks where I can be part of the care team to make sure folks get the best possible care. That's the dream. Payers and providers are going to reuse the Patient Access API, in my opinion, to facilitate more efficiency. I am of the view that it may be the 2080 rule that the value of the Patient Access API may actually be in lowering administrative frictions, maybe above and beyond the number of unique patient downloads for specific apps. And you'll see that because one of the interesting parts of the rule, of course, is that payers have to take whatever clinical data they have and convert that to FHIR in order to meet this deadline. My view, and I think it was sort of implicit in the rule, is that payers are going to be asking providers to access their FHIR resources natively. And that it may be that the payer itself might be the consumer of the provider's FHIR resource, and that from that may facilitate more burden reduction, annoyances like prior authorization or denials or any number of other ills that we see in the system today might fall short if we can facilitate the data sharing. I personally think applications that can help patients route to doctors that are right for them will be a really important use case, and the data sharing might make it easier for us to find doctors that are right for you. So don't search just on generic Yelp ratings about who's a nice to patient doctor, but rather who treats patients like me, and how might we figure that out. In fact, the Affordable Care Act spoke about the release of Medicare data to create those sorts of patients like me performance reporting, and very eager to get that policy initiative underway. But obviously, health equity is the top priority, and we've heard a lot about this in the Biden administration. My sense is that we will see more focus around patient access, I hope, tied to closing the health inequities. And so already on day one for the Biden administration, there's been a call to action to look at every program administered by the government by race, ethnicity, veteran status, disability status, low income status, and the like. And we need a new round of patient privacy controls. I obviously co-chair the Karen Alliance. I'm very proud of the work we've done on the Code of Conduct, and I'm grateful for OneUp to helping facilitate the back end of the apps that have attested, like OneUp has, to the Code of Conduct. We need more participants, and we need to put more teeth on the enforcement mechanism side. So just to be respectful of time, I thought I would go deep on the health equity discussion, because that is the one area where we have the most dire need for patient-facing apps to make a difference. If you're a Medicare beneficiary and you live in the most economically distressed neighborhood relative to the Medicare beneficiaries that live in the wealthiest neighborhood, what you find is a very sobering set of statistics that we know intuitively, but feels more frustrating when you see it on paper. You are half as likely to get the flu shot, half as likely to get an annual wellness visit, half as likely to get a care transition visit, or a third less, on and on and on. And unfortunately, you're more likely to use the emergency room for reasons that aren't necessary. So as we think about the challenges of our society, I hope the applications that come to life on 7-1 and beyond really do speak to empowering individuals with the information they need to make smarter choices. I'll leave you with this one anecdote just to kind of wrap up my opening remarks. Early, or I should say late in my tenure in the Obama administration, I had the pleasure of launching this $1 billion innovation challenge. And it was part of what was called the Healthcare Innovation Awards, something funded by the Medicare and Medicaid Innovation Center. And the idea was, if anyone in the public had an idea that would lower costs and improve outcomes, we would reward essentially a clinical trial, maybe we'll call it a payment trial, to test whether individuals who received that service got better care. And if they did, and the independent actuary of CMS validated the math, we could scale that to every beneficiary. Well, here's the vignette. The first graduate of that innovation challenge was none other than the YMCA Diabetes Prevention Program. The actuary certified a 4-to-1 return on investment. If you're pre-diabetic and you enroll in this program and you get the coaching services of the Y and you show up for these clinic, evaluations, coaching sessions, you lose weight, you don't get full-born diabetes, and you save Medicare on average $2,400 a year. On the $600 voucher to enroll in the program, that was seen as a pretty good ROI. On that evidence, in 2018, Medicare made a nationwide policy change. Any doctor in America could prescribe the diabetes prevention program. Now, Care Journey, my company, happens to have a research license, so I get quarterly updates on all the Medicare claims. At the end of 2020, a year and a half later, and we of course had the pandemic, which has a challenge, but aside from the pandemic, we never crossed more than 1,000 patients in a given year signing up for a service that we know is better for them. How could we, as a society, know that there's an intervention for pre-diabetic patients that's right for them and fail to route them to the local Y to get the service? My challenge to my patient app developer friends that are going to be on this panel, and maybe those that will follow, is that we close those gaps. If you are accessing the patient's health information and you see that they qualify for a program like the diabetes prevention program, encourage them to enroll. Do what you can to help close that gap. So more people that are eligible for a service take advantage of it, rather than have it be something that just sits on the shelf. And we fail as a society to reap the benefits. Please join the movement and become a health information fiduciary. I thank you for the time. I wish you well, and I can't wait to hear what the panel has to say.
Thank you, Anish. That was an inspiring rally cry. So certainly, really important and backed by really impressive data. So thank you for that. I think, Tori, if you want to pick up and go next.
Yeah, definitely. At first, I definitely want to thank the One Up Health team for inviting us to present some of the work that we've been, actively trying to put forth into the world, right? But also, give you the opportunity to kind of see a little bit more about what HDAI overall means and what we've been working on as well. So first, at the heart of it, HDAI, or Health Data Analytics Institute, is an analytics and modeling company. But beyond that, we are incredibly passionate about healthcare data and how we can, also allow patients access to that data. And beyond that, how can we add value to that information and make it actionable? So with regards to what we try to provide within the industry itself, is really around how we can help with the management of health. So we work with many different consumers of health data. We try to provide intelligence using our predictions for spotlighting areas of focus, such as potential hospitalizations due to adverse events, or even onset chronic conditions because of other health concerns that might be happening. Those consumers that we are currently servicing are the individuals, and we'll talk a little bit more about that with the health picture side of it. But we also help with the providers and researchers. So from a provider perspective, how do we help them improve patient care overall? And then from a research perspective, how do we help them find other areas of places that we could assist and perform some of that research and provide results? And then at the population health level, how do we take all of that information that we're learning at the patient health, the patient level, and roll it up to improve patient outcomes overall, to further population health as a whole? So from the health picture perspective, on the individual consumer level, what we were looking to try and do, obviously last year was a huge time of, uncertainty and concerns over health and how people who may be dependent on going to see the doctor on a regular basis, not being able to do so. And then beyond that, if you think about it from a perspective of a caregiver now suddenly not able to access or see their loved ones and provide any sort of care that they might have been doing, what could we do as a company to help improve that while everybody was working rigidly trying to get everything going in terms of pandemic time? So what we did is we created this app in about 3 months called Health Picture. And we focused first on presenting Medicare members with a way to see the information that was available from them for the CMS Blue Button 2.0 downloads. And then furthering that, trying to add additional value to that, but providing that data against our predictions and providing insights so that they can see that information, maybe take some action from there. And now, of course, with the patient access APIs coming forth, how can we take advantage of that and provide the same level of value that we were providing to those Medicare folks to individuals that are taking advantage of Medicare Advantage programs for anybody that's doing Medicaid or Medicare eligible individuals. So our first use case was really around how do we connect users. With regards to going back to how those individual patients were not able to access the level of care that they might have been used to. If you think about it from a perspective of, you're somebody that maybe lives in a different state and you have your parents are living someplace else, and you can't go see them. You can't just jump on a plane and go and see them and provide any sort of care, especially if something's happening. If they're having health issues, it becomes much more of a concern. So looking at ways of how can we connect these individuals through allowing them the ability to create accounts within Health Picture and then securely link them, and then empowering those folks with their data to be able to share it the way they want to. So empowering them to be able to share that information to their caregivers or be able to share it with their providers if it's needed. And then at the same token, being able to revoke that sharing. So making that more seamless. One of the use cases that kind of came in from one of our champion users had to do with, she was trying to help her father go to the dentist. And she didn't know, looking at the medications list, whether or not he was on a blood thinner, right? So just seeing the value of what we were providing, and then how else we can add information and value to the data that we have. So one of the things that we ended up doing is partnering with another company that is able to provide the information, such as what sort of brand names are associated to some of these drugs, as well as what sort of categories there are, and make better informed decisions and be able to help with the care by talking with the dentist and saying, yes, indeed, he's on a blood thinner, and that makes it much more useful for them overall. So beyond the medications thing, but giving them a curated list of all of their historical information with regards to who they've seen, what providers they've been talking with, what visit information they've been kind of having going through, and then with regards to any sort of new conditions that might be reported on their medical record. So overall, just really looking for ways to provide better avenues for conversations with their loved ones, and better conversations as well at those doctor visits. So one of the things, the biggest use case is obviously like people get access to their information, they have it all in one place. There's a lot of apps out there doing that, and I think that's great. One of the avenues that we were trying to go forward with is how do we additionally add that value with regards to our predictors? How can we help people? And to see that information up front, maybe be proactive about it. And then on the flip side of it, also allowing them an opportunity to not see that information. So it's an interesting stat. I think about 50% of our users opt in to see these insights. So it's a challenge for us to try and make sure that we're presenting this information in a meaningful way, but also not scaring them. It's really difficult to tell somebody that you are at high risk for a heart failure or a stroke. And how do you make sure that you're having that conversation with them effectively in a way that isn't frightening them, but also making it available so that those caregivers also are aware of this and they can make sure that the conversations are happening to effectively take care of them. And then in terms of seeing the whole picture, this actually leads more into what we're looking at for a road ahead. Obviously, with the patient access APIs coming into play and giving access to that payer data, we are working to try and get connected. But I think overall, it's really important for us to kind of, go in line with what Anisha said. How do we partner with data aggregators to make sure that we're presenting an entire picture of somebody's health record going forward? And the reason why that's really important for us is if you think about it in terms of predictions, yes, we're relying on claims data right now and being able to take that data, present it to our models, and then come back with it. To give them that information on the predictions. But if you think about it and you're connecting to multiple payers, you're really only getting a part of that history, especially if they have multiples. So one of another champion user that we have was connected to Medicare, saw that the information, was really excited about it, but then said, well, I connected to a Medicare Advantage plan. Now what do I do, right? So we were able to get connected. This happened to be a Humana user in the end, but now how do we present that in a way and not take on the ownership of aggregating that information specifically? And then in terms of that full health picture, the other part of this is we present tests because it's claims data. We have all of the lists of the tests that we have available to us, but we don't have a list of all of the results. And that actually ends up being one of the dominant questions that we get within our support email box is, hey, I need my test results. And it's not something we have available to us just based on the data. So how can we then link that information up and provide them that information together within the application itself and make it more actionable? So kind of back again to that diabetes thing, if we're predicting that somebody's at high risk for diabetes, how do we then present them with the same type of information that's actionable, maybe put them into that diabetes or recommend that they join that diabetes program? And then finally, with more insights, we're constantly building on our predictors and our model libraries. How do we then continually keep the flow of that information going and make sure it's helpful and presented to our users in a valuable way? So finally, I just want to give everybody an opportunity to kind of see where we're at. You can go to healthpicture.com and see the app, sign up, it's free. You can connect your information if you have it available to you. And then from there, if you want to find out more about HDAI, you can go to our corporate website. So thank you, Nolan.
Yeah, thank you, Tori. Really appreciate that. And there's definitely some great questions piling up, but we'll go through Jennifer and then get back together as a panel and go through some of the Q&A. So thank you for that.
Hello, can you see my screen?
We can, yes.
Okay, hi everybody. I'm Jennifer Blumenthal. I'm the CEO and co-founder of OneRecord. OneRecord is a consumer-facing application that enables the user to access and aggregate their healthcare information from across the ecosystem. When we started, we were really focused on medical records. I had a friend who got really sick and carried around a binder, and we naively were like, oh, well, we could just build a better Microsoft Health Vault. And that's kind of how we started working on OneRecord. To now, we kind of expanded it to not just trying to get all your medical records in one place, but actually getting all your healthcare data in one place. We're a Karen compliant third-party application, which just means we attested to the Karen Code of Conduct. We're very actively involved there. And we also are one of the only apps to get certified with the UDAP profile via ENAC. And so I'm just going to kind of run you through some high level points about OneRecord and then kind of where I see the app ecosystem going in terms of claims data and what the opportunity I think is or what people might be thinking about. So like I said, OneRecord is a third-party application. We have a iOS app, Android app, and a web app. So people can literally access their data from across any device. They can switch devices. It doesn't matter where they onboard. This is a sampling of our current EHR hospitals and connections. I just took some high-level logos and put them here, but essentially OneRecord's connected to the top 10 vendors who do have a FHIR API out. Right now that's mostly a DSTU2 version. We're watching as people are migrating to R4. We're one of the 5 apps that are enabled by the VA. So we're able to help veterans get access to their data both inside and outside of the VA health system. Something we've been working on over the past year was the ability to allow users to share their data with loved ones or people that they need to share that information with. So we have created the ability for not only users to share their information, but also to create multiple accounts. So if you have a dependent or somebody else that you're caring for, and then we started moving into notifications so that we can notify people when new data became available. The thing that my team is most excited about right now is the payer APIs. So being able to access not just the clinical data, the financial data, but the formulary data, but being able to make that useful for users. So getting medical records was always very exciting. We, when somebody wanted those lab results and they came in or they were looking to essentially create that one view, that one longitudinal record, that was fun. But now what's even more fun is being able to start working with the data that's coming out from the payers. Most of our work to date has been through the Connectathons. And then, people who have been standing up their FHIR APIs pretty early. I thought I'd do another logo garden for you, which on the left, you'll see third-party vendors who are standing up those FHIR servers that we connect to or tested against, and their clients that will be able to connect to through them to their FHIR APIs. And then people who've also stood up their own FHIR APIs and connect to them. This is not everyone in the ecosystem. These were just the ones that I pulled out that I felt comfortable showing at this meeting. So that's a high level of OneRecord. We really are focused on user experience and making the data useful to consumers. Something that we've seen is, users are used to getting data from their providers, the payers, different stakeholders, but this is really the first time that users are getting data through third-party applications. So there's a little bit of sometimes data quality problems, where maybe data doesn't look the same way as in their member patient portal as it does in OneRecord, just based off how we get the FHIR resources. And I wanted to highlight this because that's something that we as app developers have to work on. And hopefully when people not just have read APIs, but also write APIs, we can correct the inaccuracies within the data instead of the member or patient having to go to their health plan or provider to tell them their data isn't correct. I thought it would be important to say, I think today people, when they think of third-party applications, they're thinking about apps that are going to live within a app marketplace or an app store like on iOS or Android, but I don't think that's necessarily the case. I think you're going to see all types of apps pop up. I think you're going to see organizations that are going to want to leverage the APIs for maybe a consumer flow within their normal business use cases. And I think that payers probably need to prepare themselves for that not all apps will look the same. They might not all have the same education level as an organization like OneRecord within the space. And that's probably something you should have on your radar as you're thinking about this. To me, this is really the opportunity as payers are working on to comply with these requirements, for patient access, provider directory, payer-to-payer, and then so on. I think that this is really going to be the differentiator for organizations as they think about, okay, compliance checkmark done, what's next? What are we going to do? What are we going to get excited about within their organizations? For me personally, the price transparency rules is really what I'm looking forward to. Everything that I imagine to be consumer facing and forward thinking and resembling, the things that I consume outside of healthcare. I think that the price transparency rules are going to usher in that era. So I think that this is probably the place that people should be thinking about. What do they want their member experiences to be looking like when consumers not only have their data from both their providers and their payers, but also they're going to have more insights into the cost of care. And I'm going to stop there and let people ask questions.
Great. Thank you, Jennifer. This is really cool. This feels like we've hit the crest of the meeting today, because we started off with all the regulatory changes and what's happening in the industry, and then all the work that the health plans and their vendors had to do to get to this moment in time. And then boom, Tori and Jennifer show up with products that are consumer facing and consumer friendly and bright and engaging, which is, really, really, really important for all of this great work that's being done. So thank you guys for sharing that. One question, which is a big one, because it's more than like your products and it's about like human behavior, which is, how can healthcare apps start to become more and more of a go-to resource in a consumer's life? And I don't know who wants to try to tackle that one first, but
I'll go. So so there's two things. So I think the first thing from a compliance perspective for payers to think about, payer-to-payer API, where is that request going to be initiated? It's going to be initiated. I heard somebody say this earlier in the conference. Are you going to reuse those patient access APIs, or are you going to use new APIs? If the patient request is going to happen within the third-party application, that's going to be probably the first thing that you're going to see happening. I think that we're already seeing consumers use OneRecord to move their data for things that are totally unaffiliated to healthcare, just whatever their use cases are. The last thing is, I personally think people are going to build the Expedia of healthcare coming up with the price transparency rules. I think you're going to see, I imagine a point where retail clinics are going to essentially say, oh, you've had this lab test, maybe you should buy this item, go to this store. Maybe it's within their own store. Maybe Target does it, maybe Walmart does it, maybe Amazon does it. I think a bunch of the appointment booking applications are really going to leverage these APIs to do, personalized care journeys based off of your claims data and the negotiated rates. And I think you're going to see a lot of hybrid use cases. So I do not think that stakeholders should underestimate consumer demand as it becomes available and ubiquitous.
Yeah, and just from a little bit different perspective, I totally agree that we probably only scratch the surface of what's available or what's possible with having people have access to their data. But if you think about, there's already a lot of apps in the healthcare space. We may just not call them that. And things that come to mind are like Fitbit or Noom, and it's stickiness, right? It's something that's actionable. It's stuff that they can track and check in on a regular basis. And how do we do that with an app like even Health Picture? How do we do that with other apps that are trying to basically be the app that people are going to on a daily basis because there's something there that they can do? And that's where I kind of was going with the actionability piece. What can we use from the data that's available and make it something that is sticky, something that they want to go in and say, oh, I need to do this now. And they go off and they do it and check a box and gamify it to some extent so that they understand what it is, what their next step might be.
Yeah, nice. That definitely makes sense. We talked, you just talked about, Jennifer, you spoke about the price transparency piece. So maybe that one aside, what are some of the other innovative uses of this combined clinical and claims data that you foresee either your own apps or other apps implementing? Is there can you help us dream a little bit?
Yeah, so I'm going to exclude price transparency in what I'm about to describe. I think that I think it's going to be a lot of transaction-based events. So right now, like Tori just touched upon more of behavior pattern apps. I really think a lot about OneRecord and apps that look like OneRecord to be similar to when people ask us what it's like. I'm like, well, it's like Venmo. You're able to connect to multiple bank accounts and move your data across places to the people who you want to move it to. So I think about it like that. It's going to be very transaction based. It's probably going to mirror both the financial space and the e-commerce space. So you're going to use your data for specific kinds of transactions, and you're also going to use your data to create personalized healthcare experiences. And I think a lot of the personalized healthcare experiences are going to be driven by purchasing decisions. So should I buy, I got this hemoglobin test back in, oh, maybe I need this item and my retailer is pushing it to me. I really think a lot of the experiences will be around that early on. And I think the thing for health plans to think about is a lot of it will be new member enrollment, not having those insights into those new members as they come onto a plan. And this time they can onboard with all their historical data. And I think you can use that for telemedicine, all kinds of things. Just think about that intake experience. An analogy would probably be like you book a flight on delta.com, but then you have your Delta companion app to board the plane.
Mm-hmm. Interesting. Anything to add, Tori, or that covered?
No, and nothing really to add to that. I think it's a very interesting perspective, and I do agree that I like the similarity that Jennifer drew, like the Expedia app, and basically being able to utilize these apps to look for that next step.
Yeah, we have on the line with us today, I guess in the video with us today, the conference today, a lot of other app organizations. What advice would you give to them, or what do they need to be doing to go live with this type of data? I don't know if it's like a cultural answer or an infrastructure answer, or maybe all of the above.
Yeah, I would say the three things we've learned over this past, all of 2020 into 21 is it's still very early. This is day one. Like literally April 5th was only a couple of months ago. July 1st hasn't even happened. So it's very early, and you need to build your apps as really MVPs right now. You're not going to get all the data you want. There's going to be a lot of missing data. The data is going to be really dirty. So you need to be very strategic because really apps only have a certain amount of time and resources to get to market for whatever it is. So you're gonna either want to be very focused on a certain market, a certain place, something specific, and then you're gonna wanna figure out what is your data acquisition strategy around that. So for us, something we've learned, you know, just because FHIR is the standard does not mean FHIR is being used the same way it was laid out in the rules or implementation guides or wherever you read about it. Everyone has a little bit of a different interpretation. And so there's a lot of different flavors of, you know, things just around the OAuth workflows and just subtle nuances. And you're gonna have to learn that. And another thing is just the onboarding flow, like the process for each organization is gonna be different. It's gonna be time consuming.
Oh, I think we lost you, Jennifer. Yeah, we did. Okay. Do you want to pick up with anything, Tori, or should I go to another question for you?
No, I think that's actually, you know, that really hits at the heart of part of the problems or the challenges that we've had. You can imagine we started off with the CMS Blue Button data, which is very rich data set. It's got a lot of data elements in it. And when you start from that level of expecting all of those elements to be in existence in the data that you're going to be getting from every single payer, you're going to be disappointed. So we've definitely found, you know, some areas where we need to kind of reevaluate what we were utilizing specifically for the app to curate some of that data. And I think it's important for people to realize that. And she's totally right. Jennifer mentioned the data is going to be really rough and it's not going to be entirely clean when you get it. And you're just going to have to figure out what to do with it.
Yeah. Early in our presentations today, we spoke with 3 health plans and their experiences of getting their organizations ready for this type of activity. And they all talked about privacy and security and getting their organization to have to think differently about privacy and security. And I'm curious, you know, that now puts not more burden, but shifts some of the onus to organizations like yourself. How do you guys think about the steps you take or the systems you put in place to either prove your privacy and security to your users or perhaps even to other organizations?
Yeah, so a lot of it started around the communication, like how do we communicate this effectively with the users that are going to be signing up? We don't actually collect the data. Like the important part here isn't the data for us. The important part here is being able to provide value to the people that are seeing the information. So being able to see maybe the predictions that we're able to provide that help them to make better determinants of what they're going to do next to improve care. From that, it's like, how do you make sure you're right? And the privacy policy, like, how do we make sure that they're not going through that and going, oh, what are you going to do here? It's really about transparency. I feel like you need to be upfront and clear with the people that are going to be using your app and help them to understand the security measures that you've put in place to make sure their stuff is safe. And then also being clear about what happens, you know, if they don't want to share their data anymore. And for our sake, it's really, we delete the information, it's gone. We don't have the availability to it anymore. And it's the only reason it's stored there is because they agreed to connect and that they wanted to see their information in the app. And that was really it.
Got it. She's back.
Yes.
Hey, Jennifer. Let's see. Jennifer, you had talked a lot, not a lot, but you definitely highlighted the value and your excitement around the financial information. I'm curious, for both of you in your organizations, maybe if you could just comment, like, what's the culture within your companies right now? Do people feel as though you're at this moment? Do you feel even like a burden to you know, prove something, to break a new wall, whatever it might be? How does it feel to be on your side of what's happening?
I mean, I'm excited. I think I'm excited about the financial stuff because I have to say, I think when we look back in this moment of time, the payers will be the winners, just because they've been just a little bit more forthcoming and easy and like, okay, here, take it and go build something amazing with it, as opposed to the provider EHR side, which is still very concerned about a lot of things. my team is really excited because we've been trying so hard to build something that was easy to use, like very clear on what the job to be done is when a user enters into the app. And so that's fun for us to keep iterating on the design. We have a really high conversion rate right now. People who come to OneRecord convert at about 30%. Most websites convert at like 2 to 5%. And then something that we learned very early on with user testing, we always were working directly with patients, working with patient communities, co-designing, was like one of the biggest things that impact people is the financial burden. Like it's very hard to take care of yourself when the financial elements are such a burden on you. So things around finances and like, that's really interesting for me and what we can do with that beyond the clinical data. That's what makes me excited, is moving into the financial space for healthcare and helping people navigate the system.
Yeah.
Yeah, and from our perspective, it's really about people being able to see things and take action on it, right? We're very excited when we're presenting something that is, something that's clean for them to use and to be able to do something that is actually going to improve their care. I know from when we started off, we had a lot of high expectations that the real value that we were adding was on that advocate side. How do you help people who are caregivers of individuals that don't have any insight into what their care management looks like? And how do we improve that? So from that side of it, I think we really were trying to focus, and I think we're continuing to try and focus on how can we smooth that out and make that sharing process a little bit easier. It sounds like Jennifer's got some great ways of possibly adding in some value on that there. So I would be curious to kind of look at that a little bit more as well in terms of how we might be able to integrate stuff like that going forward.
Yeah, great. Well, thank you. Jennifer, when we lost you for a few minutes, we talked a little bit about privacy and security, so you dropped off at the right time. I commented how a couple of health plans who we had on earlier today had all talked about privacy and security and the changes and the adaptations that had to happen within their own teams, right, to get comfortable with this way of doing business. And I'll just say that we have a lot of health plan organizations who are on the conference who are listening, and it's really impressive, very validating, hopefully for them all to hear 2 examples of organizations that are doing good with all of this data and have the, really out there to create products that the patients and their families can use to better, their own lives and all that is sort of their healthcare. So thank you guys for sharing your stories. Thanks for sharing your perspective on the industry. Thanks for making some time for us today. And we certainly look forward to what's to come with both of your products.
Thank you.
Yes, thank you.
Okay, great. Take care. Okay, I do believe we have both Linnell and Jocelyn on the line. Hello, hello.
How you doing?
Good, thank you. Nice to see you again, or speak with
Good
you
to
again.
see you.
Yes, and
So
I got off mute, so we're good.
We may want to put him back on there just to be clear.
We'll take the small victories, Linnell. Well, terrific. So we are going to pivot over now from the app universe where we just were over to really DaVinci and all of the opportunities that the marketplace has, that the industry has, to continue to band together, to learn from each other, and to really just take advantage of the knowledge that's out there. So we're joined today by Linnell James from Blue Cross Blue Shield Association and Jocelyn Keegan. And similar format to how we've done, I'll do a quick introduction of both of these individuals. We had the pleasure of speaking earlier this week, and I'm incredibly excited for what they're going to share. I think it's very welcoming, I think, for the industry to hear. And so Linnell and Jocelyn will take us through some of their slides, and then we'll do some Q&A from there. So Linnell James, who's joined us, Linnell is a business lead for Health Information Exchange and Innovation at the Blue Cross and Blue Shield Association. He's the past co-chair of the HL7 EHR work group, past co-chair of the HL7 payer user work group, and co-author of several HL7 standards. Linnell is part of the program management office of both HL7 DaVinci Project and the Gravity Project for Social Determinants of Health, and he's a co-founder and member of the coordinating committee of the Office of the National Coordinators Fire at Scale Task Force, so the ONC FAST program. And Jocelyn is our payer practice lead at Point of Care Partners, is the HL7 Da Vinci program manager. She's a pragmatic leader who understands how to create, support, and develop the teams that build the software and products and solutions, very much invested in all that is FHIR and all that is advancing these interoperability standards. So thank you both for joining us today. And I will turn it your way for educating everyone who's listening to the conference.
Glad to be here.
Thank you.
Ready to dive in, Linnell?
Oh, of course, always. Let me start with the FHIR at Scale Task Force. I was pleased to be working with Jocelyn and several members of Da Vinci in working with the Austin National Coordinator to bring it. And part of the objective of the task force is to look at the challenges of doing FHIR at scale. Several members of both, in looking at this ecosystem, you can see that we've got to the right a lot of the ecosystem that needs to figure out how do I move this at scale. To the left, a variety of people that have specific areas of interest, whether it's a payer, whether it's a provider, whether it's making sure I know where the medical record is, making sure I know public health. All of those initiatives can be tied through the internet, through FHIR, Fast Healthcare Interoperable Resources, to get the healthcare industry up to speed with the other industries that are taking full advantage of the FHIR ecosystem. But as we get these initiatives to the right, whether it's the Caring Alliance focused on communities, focusing on consumers, Gravity focusing on social determinants of health, HIEs, the trick is how do we go from the power of this internet standard to how do we make sure it works at scale and it's interoperable? And that's really the focus of FHIR at Scale Task Force. What we've got here is a vision of how this collaborative efforts to the left, where a lot of these accelerators focused on what's the functional use case, whether it's value-based care at the top with Da Vinci, whether it's Argonaut working on the EMRs and how they work with the rest of the ecosystem and support their providers, Karen focused on consumers, Gravity, social determinants of health, Codex focused on cancer care. Those use cases then get moved. And at the bottom, I don't want to forget that Passio is looking at the post-acute care, and Sequoia, again, making that interoperable exchange nationwide. We've got all that work moving into the middle of how do I use the technology of standards, the things like the identity management, directory services, core networking, care quality, Commonwealth Alliance. And then we've got these common scalable approaches that lead to working in the community or working with the users. But in that effort, it's so important to make sure that we've got the FHIR at Scale Task Force focusing on that so that each of these different accelerators aren't doing the same thing. We don't need 6 accelerators all working on directory services when to be interoperable, we need a common directory service. We need common version identification as we move these standards up the chain. How do we make sure everybody's on the same page for interoperability? That's one of the challenges of interoperability, and we're making a lot of progress. And I apologize, we're going to be putting a lot of information into 20 minutes to leave time for a little bit of Q&A.
So I think that to Linnell's point, we're going to rapid fire you guys through this, pass through what's happening in Da Vinci, where Gravity is, and Linnell's going to be able to sort of bookend us with a little information about sort of how is HL7 as an organization scaling itself to be ready for all of this work that's headed its way. So, you know, Linnell laid out sort of what the scope is and the focus is from a FAST perspective. My team actually supports the FAST initiative in addition to Da Vinci. And we've gotten to watch really alongside our work on Da Vinci, the progression of how to identify and have conversations about these scaling challenges. And so folks like Linnell and many of the thought leaders from across the industry have gathered not just at the high level, but really around this idea of these tiger teams around specific subject matter areas. I think a lot of the themes, I was able to sit in on about half of the sessions earlier today, and a lot of the themes, and I think of the questions that you're seeing in the chat thread really are around sort of how are we going to move from people being able to do things point to point to really being able to make sure that anyone can be discoverable to anyone else, and that we have the requisite and necessary security and identity management in place. So over the beginning of the project, there really was this sort of discovery session where the industry came together with these tiger teams to identify what the technical barriers were, what the core capabilities we imagined needed to be in place, and how did we learn from the work that was already out there in the industry. And that about a year and a half in, there was sort of this initial version of these are the types of solutions we need. And then over the last year, 18 months or so, the group has really focused that on, what are the things that should be coming out of FAST and out of this community? And I think really evaluating now sort of how do we take that to action? So, all of this solution input was reviewed by our Tiger teams, led by a couple of chief architects that helped found the project with Linnell and others. We had technical learning communities that we created around each of these areas. And then we brought SMEs in to really sort of beat things up in working session style. And we're at the point now where we're really at sort of this next step of, okay, how do we actually start to create the artifacts, the best practices, the recommendations around what standards are needed, what processes does the industry need to support, and what regulation is missing that's going to stop us from being able to get to a place where we have this thriving ecosystem. I'm going to say out loud, I have a couple slides to clear that are more resources for you guys to be able to pull down afterwards, is this idea is every one of these ideas or concepts that are coming out of the Tiger teams around data exchange, around endpoint discovery, around security and identity has its own work stream. And if you are concerned about, involved with problem solving, or early adopters, come and join the conversation. There's opportunities now to connect at some of the upcoming Connectathons, to become part of the actual learning community itself. I use the LinkedIn group to just make sure I'm always aware of sort of the latest thing coming out of FAST or any upcoming presentations and updates. So I really recommend, if folks haven't already done that, to join the LinkedIn group and get involved, because this is, I listened to the last presenters talk about, sort of MVP concepts. When we're looking at where we are, we're in the infancy of real adoption and implementation of FHIR around the industry. And those of you that are here on the forefront are going to be able to give the best learnings back into the industry as possible. So with that, I'm going to actually flip and give a little bit more background on DaVinci from a program perspective. So if FAST is dealing with sort of the scaling and the how do we do this, across all of the different ecosystem players, DaVinci really is about, let's pull together a specific group, payers and providers, focused on value-based care, and how do we start to create the clinical data exchange that's required in order for people to be successful as we move the industry from fee-for-service to value-based care. Now, I would say 4 years in, which is kind of crazy, Linnell, right? 4 years in, we're looking at, use cases that are, usable by folks well beyond just value-based care contracts, and are really in this space around payer and provider connectivity. And courtesy of our friends from the feds, we'll unpack a little bit some regulatory, some work we've done to extend our work to also meet some regulatory requirements. But the core work of DaVinci is really building implementation guides specific around a use case, a business problem that needs to be solved, and then supporting that with the community, with the actual implementation guide, with reference software, sample software, and then some testing. I know some folks had asked earlier in the day about what are we doing about testing. For every one of our implementation guides we build, we actually build in test scripts to make sure that people can make sure that, I refer to it as eating our own dog food, that you're actually compliant with what's in the IG. This is just, I refer to it as a NASCAR slide of the participants, just to show, this is a fraction of the people participating in the ecosystem and funding us or supporting us with in-kind resources. But everything that we create and build from a DaVinci perspective, like the other FHIR accelerators, is available for anyone to pick up as open source. free implementation guides that are available for anyone to use. And we work really hard to keep our calls as public as possible. And with that, I'll talk a little bit about what the actual use cases are. And I think hat tip to our previous presenters, we're actually kicking off our patient cost transparency use case publicly tomorrow. And we have been having very lengthy, in-depth discussions about what that patient cost transparency use case is going to look like in API format, given the current state of knowledge and agreement about what's in the law versus what's not yet in reg versus what's going to actually solve the problems for consumers. But at a highest level, I'm going to talk about the use case, and then I'll let Lynelle opine a little bit on sort of what this means in the regulatory sphere that we've been in. So if we look at our use cases, they really are focused around sort of work areas. So how do we improve and develop standards so that data can be exchanged around sort of the attestation of quality measures, or to identify that there are gaps in care? There's an area down here to the left, which is around coverage or burden reduction. How do we create transparency and information equity between providers and payers so that people understand what is covered? And I think, again, sort of tagging to our last presenters, we really firmly believe that value-based care is the thing that is going to bring sort of this administrative and claims and pricing information back into the clinical workflow, because it's critically important for patient care for people to really understand what their options are. And their options are very much driven by what their benefits can cover and will cover. And having that rich conversation between a care team member and the patient requires we get better about transparency of information. And then member access and clinical data exchange really focus on that. How do we get the clinical data flowing so that it can be leveraged by patients, by providers, by the payer that's picking up a patient when they're making a decision to pick a new new coverage, on an annual basis. And then we have some supporting tools. I'm going to pause for a second and let Lynelle chime in a little bit about what this has looked like from a regulatory and implementation standpoint over the last year, as we're really seeing mass adoption based on what's been happening with regs. Oh, you're muted. You're still on mute.
Thanks, Jocelyn. On the diagram, it talks about highlighted in burgundy the proposed CMS rules, and then highlighted in tan the final CMS rules. We're going to have to update this because we also have proposed rules under the switch to the new administration that are on pause as the new administrator of CMS catches up with all these pieces. So it's definitely a complicated picture. But in the middle, the patient access CMS rule, which is going live July 1st. And that it was actually, I believe it was a January 1, the rule went into place, but no enforcement till July 1st. So there's a big switch being pulled on July 1st for patient access API, but also in these proposed rules, there was the effort in the envisioning of beyond payer to payer, which is part of the clinical data exchange and final rule. Over on the burden reduction, it's things like cost transparency that fortunately build off of some of the value-based care work that Da Vinci did. We can reuse. FHIR allows us to reuse those building blocks of FHIR. So what's nice about this picture of all of these intertwining proposed rules, existing rules, the Consolidated Appropriations Act with $1.4 trillion that also includes expectations of advanced EOB. All of these pieces still fit under the umbrella of the reusable pieces from ONC FHIR at Scale and reusable pieces from the FHIR accelerators, because they're built with that same R4 FHIR underlying infrastructure. So what's nice is across all of this landscape, there's reusable pieces. Now, let me be clear, reusable operationally as a payer or a large billion-dollar health system does not mean easy. It just means the staff are going to start with something for which they have 50% or 90% familiarity. So I say that and I'll wrap up, which is speed to market with FHIR and reusable FHIR-based technology, internet-based technology means that we can move quicker. And I think that's a big message, and I'll highlight a little bit more at the end. Back to you, Jocelyn.
I think that's great. And I've also included resources. The point I want to hone in on, I think, as we look at what Lynelle just shared, is this idea of using the API for one purpose then sets you up strategically to be able to reuse that API and that recipe that's in that implementation guide for a secondary, tertiary use that in the past, if we were writing custom code, would really be insurmountable for folks. So again, resources in here to go to confluence.hl7.org in general is sort of the mainstay of all of the accelerator programs, and you can get links to all of the resources we're talking about today. And then with that, I'm going to let Linnell talk about what's happening over in Gravity.
All right, thank you, Jocelyn. We talked about value-based care. We talked about DaVinci. Gravity is dealing with social determinants of health, started in 2 years ago. The association was part of that group that recognized the value of this tying to health equity strategies. So its focus is to work on data standards at the patient level to make sure we can go across multiple domains. What we've gotten is a variety of participants. I think it's well over 2,000 now, but you can see the variety of stakeholders from the clinical groups, community-based organizations, social service, federal, payers, technology vendors, all getting together every other Tuesday. It's got a public domain meeting. And obviously with some of the health equity challenges of the industry that COVID exposed, there's a real value to this. Even CAQH and NCQA from a quality standpoint have recognized tracking social determinants of health is important, not just for just care or for community engagement, but now for quality reporting has come online too. So it's a fast moving target in terms of one of the new accelerators that are making progress in this exciting new space. In terms of how we do it at Gravity, we've got 2 tracks. To the left is terminology. What are the code sets? Because one of the things we've learned in all the accelerators, the codes allow you to have to maximize your automation and tie it to technology. So they're doing gaps in the codes. We're identifying the codes. We're going and actually getting the standards bodies to recognize terminology and code sets for social determinants of health. And on the right, the actual technical side, we're building IGs, we're testing the IGs at Connectathons. We're wrapping up a ballot and expecting it to be published late June, early July, and then working with the communities to be involved in Connectathons and pilots are all happening with those 2 streams. So I think if we go to the next slide, we get to talk about I want to tie all this work back to, again, not only FHIR, but how HL7 as a hub for supporting FHIR. For over 2 years, I'm on the HL7 board. There's been a 2-year effort that's looked at how do you re-envision HL7 to make sure it's more focused, it's more agile, it's more sustainable. And as part of that, 15 recommendations came to the board from 12 task groups. I know it's an eye chart, but let me focus on 4 areas that tie to how we move the industry. So again, if we streamline how the process works, many of you know most of the standards bodies, you will spend 6 months to a year getting to know the terminology and understand their timeline and processes to be more agile and move in today's environment. HL7's got to move faster. The other things is how do you maximize those opportunities for virtual engagement? You used to have to come to HL7 and meet people and get engaged with the work groups using the technologies like that we're using right now for this conference. That's becoming more virtual and more capable. Last but not least, education, making sure the education used to be pretty much for the techno geeks. Business people like me would struggle. Now there's a recognition that it's not just the developers, but the business leads have to be involved and understand this technology to build the vision of how those pieces can be reused. And last but not least, just like Gravity has brought in community-based organizations, there's a variety of new communities that can come into the training and to get engaged. So I say all that to say HL7 is evolving, much like FHIR as a new web-based technology is available to make sure that we on this call, on this conference, can participate more effectively regardless of where you're coming from. The opportunity to use this internet technology is really amazing, and it's going to be exciting what we'll see happen in the next couple of years.
And Nolan, before we wrap up, I'd like to tag on to what Linnell is saying there as somebody that's been involved with HL7, not as long as Linnell has, but for probably half a dozen years or so, maybe more, is I think one of the things that's really amazing, and I would say, Linnell, I don't know if you agree, is sort of the unexpected sort of benefit and sort of power, not just of the standards building that we're doing, right? The ability to build implementation guides faster and to be able to convene folks around sort of these big domain problems in projects like FAST has been great. But I think this community aspect that Linnell was sort of talking about there at the end, and the ability to pull people in that aren't the coders or the architects, but really the people that understand the business problems that need to be solved, I think is a big part of how we're transforming how we solve problems as an industry. And this ability to be able to decide that we're going to figure out the rails together, and people are going to differentiate on better service, better content, better user experience, better service to their members or their patients or their partners. I think is such a sea change in the time, the dozen or so years that I've been in healthcare. I think that we're at a inflection point in an industry that doesn't happen very frequently, I think, in folks' careers. And you can hear sort of the enthusiasm of the speakers earlier today, of really the power of getting the consumer at the table, and the power of, sort of all of these existing technologies and organizations sort of pivoting and getting more agile to be able to support them.
Agreed. Here. Nolan.
All right. Well, thank you. We have had a couple of questions come in, so I think we can pivot over there, and you can keep these slides up for now because you might want to go back and reference them. Linnell, I think you shared this, but maybe if you could recap, how does one get involved in FAST?
Do you want me to take this one?
Yeah, I'll just
okay.
My team does PM support. So there's a couple ways that you can get involved in FAST. And I think the easiest, most direct way to get involved in the project is actually just to go to your LinkedIn account and join the Fire at Scale task force. There's actually a LinkedIn group. If somebody goes to me, you'll be able to see that I'm a member of the group. In addition, there's a Confluence website. There'll be links here. I'll get the slides to you guys so that you can post them and share them. But there's a way to be able to access a Confluence, an ONC Confluence-based page where there's access to all of these resources. And today there's a technical learning community that essentially allows you to be downstream of any events or conversations that are going on. And I would say candidly, and Linnell, I don't know if this is a fair statement to make, I think as we're moving from the idea of identifying what the barriers and challenges are, the best place to get engaged right now around the actual work of the different Tiger teams is actually to find out what the artifacts are that are being built and come engage in the HL7 process, whether that be coming to the work group meeting that's supporting that implementation guide, coming to a Connect-a-thon, or just pulling down the draft guides or the project scope statements and giving feedback as part of the HL7 process. The work is pivoted from sort of the conceptual to the actual around a number of the emerging areas. So that's probably the best, meatiest place to plug in right now.
Yeah, let me just quickly add that in addition to pulling down the artifacts that describe what each of the teams have done in their vision and the diagrams, there are, I believe, at least 3 projects that have been started at HL7, so you can get familiar with the proposed approach, but then you can work in the appropriate work groups of HL7. If you're involved in directories, for example, there's a work group that's assigned for that. So for each project scope statement, it will tell you which work group of HL7 is doing the work, and you can engage in the actual work, or again, participate in the pilots or connect-a-thons using some of that work. They may not be there now, but they're going to be there soon. So connect-a-thons, participation in work groups, and then participation in pilots are definitely what can happen in Q4 and all of next year. There's going to be a lot of activity here for people to get engaged in with ONC FAST. Nolan?
Yeah, I think that's just to add one more point on the pilot side, there are participants. The FAST group is actually using a number of the emerging implementation guides, the functional use cases like DaVinci use cases, to test out some of these emerging guides that are being built. So, if you get involved and you get looped in, you'll be able to find out who's actively participating and looking for partners to help with their pilot activities.
Terrific. Yeah, I feel like the two of you have the crystal ball that the industry is trying to look into. And I think you both have used the word reuse and repurpose on a couple of occasions today as it relates to the fire infrastructure and what's to come. I'm not certain every organization has made decisions with that lens and are probably always making new decisions, and so maybe if you could double back just on the question here that I'm trying to frame is double back around how you think organizations should be reusing and repurposing the work that they've done, whether it's for additional regulations or the use cases that you've helped spell out here.
Let me take a first crack at that, Jocelyn, which is because I can tie it from value-based care in Da Vinci to Gravity. So if I'm doing value-based care to improve care coordination between a payer and a provider, the care managers at a payer and the care providers at a large institution, when I turn around and go to Gravity and I'm trying to extend out to the community health worker at an FQHC or is working at a community-based organization or social services agency from a city or a state, they need the same thing. I need to know who you are, where you are, what's the latest status of your health condition. Now I want to layer on top of that, are you having problems with behavioral health? Are you having issues of homelessness? Because it's really hard to give someone a medication that needs to go in a refrigerator if they're living out of their car. And that's not something we usually ask in healthcare, but now everybody has woke up because of COVID and go, oh my God, if I don't know where they live and if they have a refrigerator or have access to food because they're in a food desert, I need to prescribe the care and resources in a new way. And those resources now can tie to the same infrastructure. Where's the hospital? Where's the specialist? Where's the food bank? Where's the transportation? All of that can run on that same backbone if everybody understands how to take it and add the missing data elements, or take it and add the different operations and the different users to be able to run off that same data. Jocelyn?
I think that that's just such a great illustration. And I think that I'll be more blunt, I think, than Linnell is, that's my role, is this idea that, you need to look at your investment in fire strategically. And we get that there's people out there that need to meet a deadline or meet a regulatory requirement. And so you might do something tactical sort of to meet that. But this idea of making data exposable, right, and making it so that you've got, more real-time interactions with your partners allows you to add more partners like you're hearing Linnell describe, right? It allows us to master data and understand our data in a way that we don't today. And it allows for a seamlessness for, a care team or, people that are in, more strategic partnerships to really focus on the patient and what's important for the patient. And I think that this reusability component isn't something controversial, but I think when we look about what happens inside of large complex organizations on a day-to-day basis, often the tactical decision gets made. And so I think my challenge, and I think our whole community's challenge to the folks that are sort of out here, is to really to get people to stop and think and take that step back to figure out what is my long-term strategy with how I'm going to make my organization interact with its ecosystem by empowering APIs. And fire just happens to be the way that we're doing that in healthcare. And we're seeing, right, everywhere else in the world that we work, all of this unexpected, unanticipated benefit of freeing information to be used in new and novel ways, securely with consent, that are going to allow us to tackle problems that we didn't think were possible, like that Linnell is just scratching the surface on.
Perfect.
The water's warm.
Yeah, no, we should go back and capture your combined answers to that question, because I think it really sums up a lot of what we've heard today and a lot of what the opportunities in the future. So thank you both for carving some time out. By the way, that your answer was the perfect transition to our next segment, which is around payer and provider collaboration with fire in place. So no better way to tee that up than your presentations and your answers to those questions. So thank you guys very much. Appreciate it.
Thanks for being here. Thanks for having us.
All right. Take care. Let's see. And Jocelyn, if you're sharing, yeah, you could.
I need to
undo
unshare.
this.
Yes, I have to get back to my screen.
I know how that goes.
I'm like, where is it? There you go.
Terrific. All right. We have we're sort of rounding home here on the journey from compliance through patient access, payer to payer, the app marketplace, what's happening on the DaVinci side of things, and the various IGs and opportunities for the community to get engaged, to payer and provider collaboration. So we're lucky to be joined by two guests here, Paul Camel from Oscar and Matt Tang from CVS Health. Paul is the Senior Director of Product Strategy and Partnerships at Oscar. In this role, he splits his time between new product strategy assessments and unearthing and evaluating key product partnerships. Prior to his time at Oscar, Paul spent 6+ years leading the healthcare analytics group at McKinsey & Company and focused on value-based care analytics and payment reform, largely for state Medicaid departments. And then Matt Tang, who Matt has a diverse background in healthcare spanning patients, providers, and payers. Matt focuses on the evaluation and execution of innovative partnerships for improving health outcomes by leveraging these advanced analytics to deliver more personalized and seamless interactions for all constituents across the healthcare spectrum that are involved in the stages of the health journey. So two guys that are very well positioned to help us navigate this discussion. The format that we're going to maintain here, we'll ask Paul to go first and share some thoughts and some materials. Matt, you can pick it up right whenever Paul wraps up, and then we'll come back in and have a conversation, some Q&A, and this session is for 30 minutes, so we'll go from 4:30 to the top of the hour.
Awesome.
Great, thanks, Paul.
I'm just going to jump in then.
Jump on in.
Thanks for the intro, Nolan. Thank you for having me and Matt on the panel. And it's been a great day so far. So hopefully we can keep it flying. I'm Paul Camel. So as Nolan mentioned, with Oscar, I've been with Oscar for 2 years on a really exciting journey as we're trying to disrupt healthcare in our own way. I was persuaded strongly to bring slides. I was hoping not to, but I will share my screen and walk you through a few pages. And just give me the thumbs up when you can see that.
We can see you.
You're good? All right. So before I talk about payer-provider collaboration and FHIR, just 1 minute on Oscar. Some folks might not be familiar with us. We are a health insurance / health tech company. We have been around for almost 10 years now and really came about as part of the ACA. And our mission is really to make a healthier life accessible and affordable for all. That's a very ambitious mission, but every year we make progress on that front. I think most recently with our virtual primary care and free incentives, we really see this being brought to life. We describe ourselves as the first health insurance company built around a full stack technology platform and a relentless focus on serving members. When I say full stack technology platform, I mean that in the literal sense. There's very little in the Oscar ecosystem that is not our homegrown software, whether that's our core claims adjudication system, the CRM that our care guides use, the EHR that virtual primary care providers use, our care navigation, our digital experience, and so on and so forth. And then the way we really see the world is building engagement and building trust with our members such that can drive value. And so, through that trust and through that engagement, we can connect deeply with members. We can trigger specific interventions. We can collect data that we can use to help them navigate a very complex healthcare system. We can deliver care ourselves with our affiliated virtual primary care practice. And then last but not least, we still have all of the insurance capabilities in terms of innovative plan design or dynamic incentives to really support the virtuous cycle, which creates more engagement and trust. So that's the backdrop of OSCAR and how we see the world. As it pertains to payer-provider collaboration with FHIR, I reflected on a few things that we've learned that I'm going to share. And just generally speaking, I think we're still very early on in the journey. We think it's a very exciting journey. The innovation and consumer-centric capabilities that will arise from this are very exciting. Some of the things that we've learned is we've tried to establish FHIR collaborations with different providers are as follows. As with a lot of things in healthcare, aligning incentives between all parties is really important. OSCAR broadly partners deeply with our provider partners. We are mainly a narrow network product, and that is built around specific provider partners. So we already have a good start on that front. And going forward, even more today, we are building and developing value-based care arrangements. And this is critical because the things that we care about and the member cares about and the provider cares about all come together. And that feeds nicely into the next bullet, which is focus on value creating use cases. There's an infinite amount of things that we can do as we create standards and open up the exchange of information. And when we look back 50 years from now, we will have accomplished those million things. As we're starting, it's really important to pick and choose those use cases and recognize that people see the world slightly differently. I think it was Alex that alluded to some actors in the system have some concern or some reservation in terms of what the impact of this is going to be. And it's important to be thoughtful on that front. What really helps payer-provider collaboration is to simplify and not complicate. So what this means in particular is, providers operate in a multi-payer environment and a multi-point solution technology environment. And if you are a payer that's coming to the table with another proprietary capability, another proprietary point of care tool, there is a barrier to overcome in that. And if you come with a tool that's more broadly applicable beyond your own, the payer membership, there's a better opportunity for them to be able to deploy that in their workflows. The other sort of somewhat related point, but distinct, is that we believe, particularly now, it's important to meet providers where they are. There's various reasons why different organizations are at different places, and some of them might have, FHIR capabilities. They might have a technology team, and they might be able to support various integrations or APIs. Others might choose to do everything through their EHR, and others might have purchased a third-party solution, a point of care tool, et cetera. And at least where we stand right now, we are open to being able to meet providers where they are. I think we definitely want to measure and contrast different options and understand, the ROI and the adoption and the consumer experience. And I think over time, we'll have a better understanding of, the efficacy of different paths. But as of now, I think we're open to different modes of collaboration. Invest in learning. This is early innings, and it's very complicated. Despite having a standard, there's EHR nuances, there's, partnership specific nuances, and we're still in that process. And as we build those capabilities, we also want to work with our provider partners to share those learnings. And again, I think that's going to be a catalyst for increased collaboration. And last but not least, we think it's critical to partner effectively with different health tech organizations. I contrast this with the slide I shared
2 slides ago, where Oscar is a full stack technology platform. But the dynamics of healthcare have shifted a lot in the last 5 years, and there's a tremendous amount of high caliber, innovative organizations out there. And so we believe that it's really important to partner with the right ones. I'm very excited to be here with Nolan and the OneUp team. We are partnering with OneUp for our interoperability needs. But beyond that, I think that's really going to help decrease barriers to collaboration when there's common infrastructure and common ground that you can leverage and sort of turn on different use cases quite easily. So I'll pause there. Matt, we'll hand it over to you, and excited for questions at the end.
Okay, great. Let me see. Getting used to Zoom. Can everyone see my screen okay?
Yes, we can.
All right, fantastic. Well, it's an absolute pleasure to be here with everyone today, and I'm glad to be paired up with Paul as part of this panel discussion. We had a chance to connect yesterday for the first time and realized that a lot of our objectives are very much aligned in terms of what it is that we're doing. It is really energizing to be surrounded by this community, and I'm hopeful that we can continue to drive the momentum coming out of this virtual health conference. So I'll just give you all a little bit of a background in terms of what we do here within the Analytics and Behavior Change Division here at Aetna. But I'll start at a very high level with what is our overall mission as a healthcare company, and at the end of the day, that is to really join our consumers in their pursuit of their health ambition. And you could tell even during Paul's presentation, I think we're all kind of chasing the same goal here and want to deliver on that same type of experience. When it comes to really joining the consumers, our analytics organization really plays a central role in driving the advanced analytics efforts to accelerate our ability to deliver on that objective. And so in terms of what we do within analytics and behavior change, it's very much synonymous with the name. We have a 2-part mission. How do we continue to enhance and invest in the development of advanced analytics capabilities, artificial intelligence, to really integrate and drive the insights and efficiencies into our business operations and the way that in which we engage with our consumer. And then more importantly, we constantly talk about being consumer centric. And so at the end of the day, it's really about the application. So how do we really bring that into fruition through the behavior change principles that are going to help give the appropriate information to the consumer at the right time, at the right place. And throughout the rest of today's conversation, I think we all heard a lot about kind of practical value, making sure that the information is truly insightful and actionable. And that's what we're looking to do here. So I'll kind of shift to our next slide. So in terms of, what are the 6 key areas that Aetna as an organization is focused on to really help our consumers achieve those health ambitions? It's 1, we're looking to develop a deeper understanding of the consumer and really breaking down those historical data silos, which makes us really excited about FHIR. The second is around multimodal engagement strategy. So what can we do to really leverage FHIR to create more of that seamless experience? In doing so, trying to kind of put that all together and really drive tailored offerings to enable a truly holistic care model or coordinated care model. And then really putting our consumers at the center of that and always putting them first. And similar to what Paul alluded to, is realizing the changing dynamics in healthcare is that we're seeking to engage in groundbreaking partnerships with very consumer-focused companies. When we think about what it is that we're doing here, a lot of the focus at the end of the day is on the consumer, and folks are probably wondering, well, Matt, this is a session on payer and provider, and how we're going to really integrate with FHIR. And so we think of providers very much as a consumer. They play such a critical role, not just in the patient consumer journey, but they themselves are also consumers in terms of the way that they're going to be receiving information and how they can act on that information. And so at the end of the day, in order for us to be able to really position all stakeholders within the healthcare ecosystem to drive better health outcomes, it really does involve a holistic approach. And so as we think about how we continue to engage with our provider community, something that came up earlier, I think during Stephen Posnak's session, where he talked about how, fax is still a primary mode of communication. We're looking to really, accelerate the transformation beyond that, and trying to do so in ways that we're seeing in other parts of the consumer industry, leveraging of applications, and trying to also do that for the provider community. And what Paul alluded to a little bit earlier as well was around kind of that multimodal, meeting providers where they are. And we realize that there are going to be some providers who are kind of self-selecting their own population health tools, add-on clinical decision support platforms that sit on top of their EHR, or some are going to rely purely on their EHR. And so it's really critical for us to really think about, what's going to work best for them in the short term, and then how do we think about kind of where the future holds. Ultimately, at the end of the day, when it comes to the provider messaging and how we share the actionable insight, it's really critical to think about kind of, your traditional who, what, when, where, and how. And that's really important as we think about the way that we've sought to engage our provider community. Rather than boiling the ocean, we really started with kind of a use case driven approach, and trying to get very tactical about, how do we frame up the different features, what we could potentially enable, and then identifying very specific metrics and actions that we're looking to achieve, and really testing that to understand in the current state, what could we deliver on in the short term, and then how could we continue to accelerate and maximize that impact going into the future. So the way that we go about that, it is a very collaborative process. I think what we all have realized as part of the FHIR journey is that we're all still very much learning, and so ultimately we're continuing to try and figure out how to best partner with those providers, really take those lessons learned, whether they're good, bad, and really use that to inform how we continue moving forward in our partnership with our provider partners. So I think another point that I didn't bring up earlier was, another point that I wanted to bring up is around kind of remarks earlier around the information, the data that health insurance or managed care organizations do have. We're going to have historical claims data that we think is really critical for sharing with our provider partners. And so some tactical metrics are around history of medication adherence, information around open gaps in care, and how do we really share that information with our network of providers that's going to be actionable to them, allowing them to really work within their within their integrated workflow. At the end of the day, as we continue to partner on all of this, our objective really is to drive better health outcomes. We think there are really 3 areas of value that we expect to come out of all of this, and it's going to be improved patient experience, because it's going to create that seamless patient journey. It's going to reduce a lot of burden for our provider partners, and then ultimately driving overall health outcomes that will come with that.
That's great, Matt. Thanks. Is that the wrap up?
That's the wrap up.
All right. Thank you. You left me hanging there for a second. Well, great. So thank you guys. A couple questions have shown up, and then I probably have one or two I want to direct this to first, which is, Paul, you mentioned at the beginning aligning incentives and that being really fundamental. Maybe either doubling down on that or in addition to that, how do you encourage your provider, the providers in your networks to collaborate with you? And what have you seen that gets them more willing to do so than not?
So I think generally providers are really excited to collaborate and partner with Oscar. I think we bring a lot to the table in terms of technology capabilities, and then our focus on member experience and sort of that aspect to it on the consumerization front is really exciting. And so I think we are often seeing providers that are interested in that component, right? I think clinically providers know exactly what to do, and when they're seeing patients that we're not in that mix, it's like when the patient leaves the office and the provider needs them to do certain things or adhere to certain things. There's a lot of value that we as a company that has that deep relationship with that patient can bring to the forefront. And, we can do that as a payer partner, right? And how can we align our care management programs to theirs, or how can we provide them with the right information? Or if we know our patients are searching for things in the app, how can we let them know? So I think there's things that we can do that are really value add. And then I think quite interestingly, in the last 3 months, we sort of announced that we want to bring our platform to payers and providers. And so how can we collaborate with them by offering all of the things that we have? I think that's an exciting avenue. So we definitely get a lot of traction and inbound and excitement. And as like all things in life, it's a question of prioritization, and there's 1,000 things we can do. And so I think we have to be selective. But overall, I think there's a lot of opportunity for collaboration beyond just the incentive component. But that's also really required, right? Because we are a newer payer. I think we have 500,000, just over 500,000 lives. I think Matt on the CVS front must have something like 25 million or so. And so I think we have to be conscious of that as well.
Yeah. So then Matt, how does it differ for you? So two different organizations, different DNA, right?
Yeah, I mean, and so, the way that we think of it, I don't think that it changes. At the end of the day, we're still one of multiple payers that our providers are working with and are part of the network. And so the incentive alignment is still very critical to what we're able to do. Luckily for us, given the position that we are in, we do have fairly substantial value-based arrangements that are in place. So when you think about the financial and the clinical risk that's associated with that, it does create a platform for that conversation. But as Paul and I have both talked about, it's still very critical to really meet providers where they are. And so for us, it's about aligning some of those early use cases with, what are the key pain points that the providers are seeking to address? And whether that's purely a provider experience play? Are we talking about issues as it relates to their quality measures as part of that value-based arrangement? And every conversation with each provider is going to be slightly different, and therefore our priorities will be different, but we're looking to create some sort of commonality across all of those various conversations.
Okay, cool. One just came in. This is this may or may not be in either of your wheelhouses. So if it is, we'll take it. If it's not, we'll pass.
Thanks for that. For giving us an out. I appreciate
the advance out for sure. It's the only way to do Q&A, Paul. What does your roadmap look like on the pharmacy benefit side? I'd love to hear any update on APIs for pharmacy pricing, particularly any comment on NCPDP versus FHIR.
Thank you for the out. I think that's
all right.
A highly specific question, at least on my side.
It is very, very specific, but didn't know if you knew anything. Matt, same for you?
Yeah, unfortunately, I've got nothing either. At a high level, there are some explorations into kind of the benefits check component, but as the details around pricing, I'm not privy to that.
Okay, well, we'll take credit for asking it and you know, taking a pass at it. Maybe just back to working with providers and having them seeking their collaboration with you. You know, you guys as the health plan, when you're analyzing these types of initiatives, you're going to be looking at certain KPIs. Matt, you said it in one of your comments around, you know, specific metrics and specific actions that you're looking to influence. The provider, I assume, is looking for something as well. Are those KPIs always aligned, or how, you know, are they looking for something different than you? How do you guys think about that?
So kind of going back to how we break it down, right? We're going to prioritize those use cases that are mutually beneficial to start. I think when you think about overall KPIs, right, we can, I think as an industry, we refer to, you know, consumer member NPS, and then what are we doing to really drive down overall medical cost trend? But then when it gets into the tactical use cases, and I think the point made earlier was we're still learning so much about what we could potentially do. And so inherently, as part of the use case implementation, you're going to see very operational metrics. So looking at the number of patients who, you know, picked up a medication, the number of patients who went and got a lab test done. And so those are going to be our leading indicators. And then ultimately, when we think about the outcomes metrics, are lagging indicators, you know, that's where we'll really start to focus more on medical cost savings, overall utilization, and how we're potentially bending the trend there.
Yeah, and I think that's exactly right. You know, to keep it simple, Nolan, there's value creation and there's engagement. On the value creation side, there's a lot in there, right? There could be MLR savings, there could be patient outcomes and adherence. And then on the engagement side, a lot of the stuff that we're doing, we want to make sure it's being used. And so if you take like a Smart on Fire app, okay, great, we're collaborating. They installed the thing, but no one's using it. And so I think like how often are provider partners, you know, when they're seeing an Oscar member or, you know, Oscar patient, actually leveraging the information, and if they're not, you know, we'd have to iterate, because that's sort of another leading indicator on, you know, the ability to have that downstream value. And I think the other thing that's like extremely complex is the user is often not the buyer of the arrangement, right? And so you might be agreeing to doing really innovative things with you know, the leadership of a system, for example, and then there's the dissemination of an initiative to a physician that's using a capability at the point of care. And while you hope those are always aligned, you know, those are just different individuals. And so I think we have to be thoughtful in terms of, you know, striving for KPIs that create value for all of the audiences, both on the provider side and on the member side.
Yeah. Yeah, well said. You know, I have the pleasure of getting to work with both of you, you know, in different environments. You two have very important and influential jobs at some of the most important and influential healthcare companies in this country. And, you know, being on the product strategy and partnership side, Paul, on the analytics and behavior change side, Matt, you guys see stuff that a lot of people don't see, and you're doing, you know, projects and initiatives that are certainly driving change. So thank you for the work you're doing in the roles you have. Thank you for joining us today, sharing some of your perspective and some of your trade secrets and your perspective on, no trade secrets were shared, I know that, and your perspective on collaboration, you know, going forward. And hopefully what these new fire standards and the new infrastructure taking place on the payer side, the health plan side, can start to really map to some of the infrastructure that's on the provider side, and should be an interesting path forward. So thanks again, guys.
Absolutely. Thanks for having us.
All right. Take care. All right. So that brings us to the end of the presentations. We'll wrap up here I'd like to introduce Joe Gagnon, who's the Chief Operating Officer of OneUp Health. And I'll do a very short bio. Joe might do more, we'll see. But Joe is the founder of the High Performance Life, which is a brand that Joe has created, and there are many aspects to it. But it really centers around his mission to help others achieve their full potential. And that's what Joe is doing in his role at OneUp. He's helping the company and the organization achieve our full potential. He has the responsibility for strategy and daily execution across the business, which includes leading the functions of sales, marketing, finance, HR, implementation, and operations. And we were able to steal him for a few minutes amidst all of those responsibilities. So Joe, we had an awesome day, a lot of speakers, some incredible insights were shared, and we'll hand the baton to you to take us home.
All right. Well, Nolan, thanks. I was enjoying listening, and I think you have a good role there as a moderator. So well done. Yeah. And so just, before I jump into some final comments, at a personal level, I find this whole idea of data interoperability sort of stunning and monumental in any of our personal lives, because if you really are about optimization, what you know is that the data that you have at your disposal changes the way you live. I mean, we wear these watches that track our sleep, our activity, our heart rate. We can have apps that tell us about our nutrition. There's so much that we know at a personal level, and yet it needs to connect back into the core of our health data in the health system, whether that's from a provider or the payer, maybe even more broadly to all people who might be like us who we don't know. There could be some person like Joe Gagnon out in Portland, Oregon, who lives a similar lifestyle that I could benefit from knowing at a population health level, what's going on in his or her life that would help me better think about optimizing my performance, my life, my financial situation. And, the truth of the matter is what we talked about today is sort of foundational to that. I've been waiting for this moment for many, many years, and which is why I really wanted to join Ricky and the team last year, because, as we think about, fire as an enabler, I think the world has the potential to truly change. And so I'm not exactly sure how many of you have stuck with us the whole day. And if you have, a huge thanks. I appreciate that you're still here. And, very shortly we'll get back to your day job or your night commitments. And to Nolan's point, it was quite an amazing day. Every time you set up an event like this, you get sort of a little worried that it's going to all come together. And I think it really did. We'll talk about the speakers in a second, but overall an amazing day. Great speakers with great ideas, a bit of a glimpse into the future of what's possible, and a whole bunch of practicality, which is really important to us. And you got it all in one easy to access forum. We are truly thrilled to support and sponsor this event. This is our third time we've done a VHC, and you can expect we're going to do this going forward in the future. As Ricky mentioned at the outset, fire really has truly arrived, and it is a unifying thread across healthcare. I mean, this is the first time that claims and clinical data have come together in the same format, and that's not an understatement of how important that is. And it's going to help us uncover new opportunities ultimately to live longer, healthier lives, more functionality, more capability, time to run, time to spend time with your family, do work, whatever it is. And I don't think we fully understand how big of an impact fire is going to be. That the data standard itself is something, but what we heard about today is that the next 3 to 5 years are going to be very exciting. I think our clinicians and our healthcare workers and the system actually operates very well at that sort of personal knowledge level. But we have yet to incorporate all of the reams of content and data that could help us do better at what we do. Whether that's either not just an EMR and a claims record, but, sensor data over time, radiology data, genomic data, and then that all important one-day patient reported outcomes and data that we've tracked. All of this can end up in FHIR. And as you heard today, we're going to be able to access in real time this data to allow us to make better and faster decisions. It'll even get more interesting as AI and machine learning start to touch on, how it is we think about the analytics that can come out of this, the patterns of data, the insights, and the ability to act and operate. To the best degree possible, I think we saw, in a somewhat scary way with the pandemic over the past year, that the mRNA vaccine was driven from, 17 years of modeling, but it really was an algorithm that figured out how to take a pandemic and bring it down to its knees. Once we started getting vaccinated, our death rate and hospitalization rate went down significantly. And driven by researchers, powered by data. That is a glimpse into the future in a very, very deep way. I think it's going to be really, really exciting. Ricky also thanked the people who have, I think, sometimes you forget that people who set standards are actually game changers. We'll go back in time and think about Tim Berners-Lee and the World Wide Web Consortium and HTML and HTTP. Those standards changed how we think about sharing data on the World Wide Web, and FHIR is doing the same, driven by people like Graham and Ken and Josh, Dan and Nish, Virginia, all of our friends at the work groups like Da Vinci and Karen and the Fireball Analysis Alliance, and this is, there's often sometimes I think when we go to these committee meetings, we wonder if what we're doing has an impact. And I think, on July 1st, we're all going to know that the ideas that were conceived years ago that went through all the committees, that got into the hands of the ONC and CMS, that are now all of our friends and customers and players in the industry are starting to use, we will see the benefits of that come to life when a patient can access via a patient app their claims data on July 1st, something they've never really been able to do before. Today we really did have the best minds in the world talking about FHIR interoperability. Alex Muggy from CNS and Steve Posnack from ONC talking about regulations. It's really important for us to embrace that and also thank them for their work. Our panel, I thought lots of great insights about APIs. And, who would have thought 10 or 15 years ago that APIs would be at the center of how we think about technology? But boy, have they sort of redefined for us, almost like currency has around the world redefined the ability to do commerce. APIs are allowing technology to work as never before. It was fun to listen to Kyle, and then the panel moderated by Anish. That was just awesome. When you think about what people and the people on the panels today were talking about, it's clear that we're not just at the early stage, but real progress have been made. Wrapping up almost, Jocelyn Linnell, who really talked about how Da Vinci Group is making real insight and moving us forward. And then it was fun to listen to Matt and Paul, practitioners working right in the middle of this with Aetna and Oscar Health. Wouldn't have happened, of course, without the OneUp Health team who worked tirelessly to pull this off. A huge, shout out to Christina Butenko, who, as you all know, she's a really determined and amazing person who is the center of putting this on, who wants to give credit to everyone else, but we really want to thank her for this. And then a huge thanks to everyone who attended the virtual health conference. We hope you enjoyed the day as much as we did. We will do this again. We'll have one in the fall, and we will make sure to have the content as engaging and entertaining and valuable as it was today. Thanks very much. Hope you have a wonderful day, and we're looking forward to July 1st, like each and every one of you are, in a very, very deep and exciting way, and then move into the summer, I think, free and clear of that deadline that has been looming over us for so long. Thanks again. Really appreciate it. We'll talk to you soon.